Okay, so we're recording. Okay, so obviously tonight we're going to cover pediatrics. It should pretty much, this chapter is pretty long, so it should fill up pretty much the whole night. And then tomorrow night we're going to finish up most of the rest of the lectures, and then we'll start going into review mode for the exam. So really, for all intents and purposes, the class is kind of done. I'm going to put together a little quiz, or a little, not a little, but I guess a final exam on the entire course that I'll hopefully send out before Shabbos. And then you just need to let me know by the end of the class if you guys want to get together. Those of you that have been signing on for Matzah Shabbos, if you want to do another Matzah Shabbos session. Okay, but you don't need to tell me now. You can tell me at the end of the class. Okay, so a couple things that we know about kids. So obviously, children are smaller in size than adults, but physiologically, how the body works is a little different in kids because obviously the pediatric body is growing. Okay, everything is kind of working faster and harder in a child. So if the body is working faster and harder, it has a higher demand for the nutrients, for the good things, for the oxygen, for the sugar. In other words, all the things it needs to stay alive. So we're going to see as we go on in the chapter how kids don't tend to tolerate, even though we would say they have a pretty healthy body, have no disease and stuff like that. Kids don't tend to tolerate being deprived of oxygen and things as well as a healthy adult would, right? Because they don't have reserves, right? I mean, even blood, right? I mean, we have extra blood. Children really do not start developing extra blood till they get into their teenage years. So they don't really have a lot of extra blood. They don't have enough, because they don't have a lot of extra blood. They don't have a lot of extra capacity to carry oxygen, right? Because in the blood is the red blood cells and stuff. So we'll talk about all that type of stuff as we go on. Okay. So we're going to go through all the parts of the body and talk about how they're different. Okay, not just that they're probably smaller, but how they're different and how it plays a role in what we do. So the first thing is that the back of your skull is called your occiput. Okay, and in kids it tends to be almost, I don't want to say pointy, but like very rounded and very what they call pronounced. In other words, it kind of sticks out. So that in some kids, when they lay flat, okay, they actually close their airway. It's called flexation. Like when you flex your muscle, it's called flexation. So they actually tend to flex their airway closed. So one of the things we have to be aware of is if we see a child supine or we put them supine, okay, that we may need to apply padding under their back, okay, whether it be towels, blanket, whatever, just to build it up a little bit so that the head is in a neutral position. Okay, so that's one of the things we always have to worry about if we're, putting a child supine. Okay. Now, when they say proportionally larger and heavier than an adult, what it means proportionally means that obviously it's not larger and heavier than an adult's head because an adult is larger. But if you take into account, if you measure a child and say, okay, the child is 2 feet, the head in a pediatric patient is actually heavier, okay, and larger than in size. In other words, than it should be for that 2 feet of height they have. So that's what they talk about that. They even say that I have never seen it, but there's issues where kids lean over. Let's say like they lean over to look at a pool or look in water. Their head is so heavy in comparison to their body that they actually go right into the water and stuff like that. So it's one of the risks of drowning, that a kid may like lean over to reach for a ball or look at the water, or look at a fish or something like that, and will actually go, head first. And because of that, we always have to have in the back of our mind that there could be head injuries, right? So mechanism injury could be they fall and land on their head. Now, we said the other night that there's soft spots on the skull, right? When we're talking about closed head injury with rising intracranial pressure. We said there's soft spots in the pediatric skull, okay? One set kind of closes up about 5 months, the other about a year. But those fontanelles or soft spots, okay, are there to allow, as the brain is growing and to allow room for expansion, as to allow the skull to continue to stretch and expand to fit the growing brain in there and stuff. So a couple of things that if the fontanelles are curved inward, like they're depressed, like as if you stepped on them and you made like a hole, that could be a sign of dehydration. And if they're bulging outward, like almost like a balloon, like they're bulging outward, that could be a sign of intracranial pressure, right? So that could be something you could see in head trauma. Okay, because remember, it's exerting that pressure on the skull. It's just that when the skull is intact, it has no place to go, so then it pushes the brain down through the foramen magnum. It could also be a sign of an emergency we're going to talk about tonight called meningitis, which is an infection in the lining of the brain, the meninges, right? Your dura mater, the lining of the brain and the spinal cord. So a bulging one basically means there's too much pressure, okay, and it shows through the fontanelle. And again, it could be either head trauma, okay, or it could be meningitis. A depressed one is usually a sign of dehydration. Okay, so we'll talk about those. So, I mean, just, the question would be, I mean, nobody's rough with a child, but obviously when you're handling a child, just to have in the back of your mind that there are those soft spots, and just to be watch where you put your fingers and stuff like that. And I'll show you pictures of where they are and stuff like that. Okay, now as far as the airway goes, so obviously the mouth and nose are smaller, so it's obviously easier to obstruct them. They primarily breathe through their nose, right? They're called obligatory nose breathers. And we said that's because babies are designed to breastfeed. And when they're latched onto the mother's breast, they have to breathe through their mouth, obviously. Now, because of that, if their nose is clogged, like they have a runny nose, they're going to have more issues as far as having trouble breathing than we would. So they don't normally breathe through their nose, through their mouth, unless they absolutely have to. So when their nose is clogged up, it can cause a problem. And sometimes it's easy. I mean, most of the times the parents deal with it, but again, you could get parents that are not so, with it, or maybe they don't, the first child, they don't know what to do and stuff. The parents aren't available, their parents aren't available, the grandparents. And really, a lot of times it's just a matter of taking a washcloth with some lukewarm water and cleaning, the outside of their nose. Sometimes we have to go, maybe a little more aggressively and take like the bulb syringe from the OB kit. And again, with a little warm water, just spray a tiny little bit of warm water up there and then suck out the mucus. Obviously, the kids don't like that. They're going to cry. They're going to fight. But a lot of times if you see that they're all congested and it looks like they're having trouble breathing, it could be that they just need to have their nose cleaned out a little bit and they may feel better. The other thing that could happen when a child has excess mucus production, right? Mucus is the substance that lines our airway to kind of catch the dirt. So when you have a cold, the cells that produce mucus kind of go into overdrive and produce a lot more. So if you have a lot of mucus, right, where does that mucus go? So once it kind of comes up out of your airway, it comes into your throat and you actually swallow the vast majority of your mucus into your stomach. Okay, very little of it comes out your nose. So when you have too much mucus production and it drips down into your stomach, it can make people feel nauseous and even vomit. And then they vomit this kind of streaky, looking vomitus, which is all the mucus in it. And it tends to happen not so much in adults, but more in kids. Sometimes also in cystic fibrosis patients that have also a problem of a lot of mucus. Sorry. But sometimes the parents call you and say the kid's huffing and puffing, having trouble breathing, then he started vomiting. And a lot of times after they vomit out all that mucus, they actually feel better. Okay. Now also the tongue is a muscle, right? And all the muscles in a child are not as well developed. And it also takes up more space in the mouth than an adult tongue does in an adult mouth. So if you have a muscle that's weak and a patient is unconscious, it's more likely to obstruct the airway. So, what we were talking about. And remember, the sound of a partial airway obstruction caused by the tongue is snoring, right? So it just, in a child, especially if their head is flexed forward, it would be likely to hear snoring. Okay, so again, we're just going through the different things. Okay, the trachea, right, has rings of cartilage that hold it open. So those rings of cartilage are not yet hard. So it's softer, it's easier to obstruct. Okay. Again, swelling, we're going to talk about some different types of infections that could happen in the airway. They could cause swelling. And again, because it's smaller, it's easier if they have a foreign body, I don't know, a toy or something, a piece of food, it's easier to obstruct the airway. The nice thing about it is that since the airway is relatively short, okay, you usually are very easy. It's very easy to clear it out most of the times. Okay, unless it's some kind of soft, gooey, sticky type of thing that they have in there. Okay. The ribs are not as hardened yet, right? So it's easier for them to have chest trauma. It's less likely for them to have rib fractures because the ribs are soft, but it's easier for them to have trauma to the organs underneath the ribs, the lungs and the heart and stuff like that, because the chest wall, the rib cage is not that hard yet. And kids primarily breathe with their diaphragm. I'm sorry, I should say a different way. We all primarily breathe with our diaphragm. That's our main muscle of breathing. But when we need extra help, we use those intercostal muscles, which are between our ribs and over our ribs to help us breathe. Okay. So I would say in most of us, it's probably 80% diaphragm, 20% intercostals. Kids don't really use their intercostals again till they move towards the later part, like, say 10, 11 years old. Don't use them that much unless they have to. Okay, so the main muscle of breathing is the diaphragm. So if you're only using one of your muscles to breathe, it's just more likely that if you're having trouble breathing and breathing very hard, that you could tire out that muscle, right? And then they go into what's called respiratory failure. Remember, we said there's respiratory distress, which is a person having trouble breathing. There's respiratory failure, which means that because they were having trouble breathing, they were working their muscles of breathing so hard, their diaphragm and intercostals, that they tire them out. Okay. And then it could still look like they're breathing, but they do that shallow breathing where they only move the air in what's called the dead air space. So the dead air space is every place above the alveoli. And the only place we could have gas exchange, we know, is between the alveoli and the pulmonary capillaries. So if we're only moving air in our nose, our mouth, our throat, our trachea, our bronchi, it looks like we're breathing, but we're not getting enough volume, right? It's called tidal volume. We're not getting enough volume down into the alveoli. So that's one of the dangers. Now, if a patient's going into respiratory failure, that would mean their oxygen level is dropping and their carbon dioxide level is rising. So there has to be a change in their mental status for the worst if that's happening. So one of the signs you'll see as a patient starts going into respiratory failure would mean that their mental status has to decrease, right? It has to get worse. And that's the indication to you that you can no longer what we call passively treat them. It means you can't strap a nasal cannula on them. You can't strap a non-rebreather on them. Even at that point, probably CPAP is no good because remember, for CPAP, they have to be wide awake. So it just means that at that point, like trying to give them a nebulizer won't work because they're not going to breathe it in deep enough. So at that point, really what has to happen is the bag valve mask has to get involved, because now when you use the bag valve mask, you're forcing air into them and you're getting air down to their alveoli. So you're taking care of the fact that they have that poor, tidal volume by ventilating them. Now, CPAP could be useful before they go. So if you see it looks like they're getting tired and they've been breathing hard for a long period of time, right? That's what the family tells you. Putting a patient on CPAP, okay, may help. The problem you're going to have is that the CPAP protocol basically limits you, I believe it's to a child of 12 or something like that. So you can't really go into the smaller size kids. And that's probably more of a limitation, on the actual CPAP devices that are available for the field use, right? They don't have very small masks and stuff like that. Okay. So again, diaphragm, main muscle of breathing. Okay. Thorax, the size of your chest, tends to be obviously smaller. So it's closer to your abdominal cavity, which is full of organs, and your diaphragm. So it may make it harder, okay, especially if they're crying and getting air in their stomach, to have the diaphragm go downward. So remember, when a patient's breathing in, right, their diaphragm goes downward to make their chest cavity bigger. So if their abdomen is in the way, right, if their stomach and their abdominal organs are in the way, it's just going to be harder for them to take a deeper breath. So we're just kind of going over all the issues we kind of see when we see kids and stuff like that. Okay. This is not kind of really a thing that we really notice. Neonates, if you remember, we said were children in the first 30 days of life, right? So in other words, you deliver them, and for the next month, they're considered a neonate. So just the shape of their chest, okay, is not like the shape of our chest. Theirs is more like a box, okay, and that makes it a little harder for them to take a full breath, okay. So somebody said, Mayor said, what's rather BVM or mouth to mask? Okay, so we do not have masks on the ambulance, okay, mouth to mask. So hold on for a second, let me just mute everybody. Okay, so we don't have masks on the ambulance. I've never seen anybody do mouth to mask except like, I don't know, lifeguard or something like that, right? So we don't use that. We use the bag valve mask, and we have different sizes of bag valve masks to adequately treat different ages of patients. Okay. Now, the only thing I could say is that if you were using a mask, okay, ventilating, so you're blowing into it with your mouth, if you start to deliver too much air, you're probably going to feel some resistance to your breath. And that would kind of be an indication to let you know that you're ventilating too much. But nobody uses a pocket face mask, whether it be in the hospital, in the field or anything like that, to ventilate patients. It's just not done. It's just not the way we deliver, air to patients. So it says, because I saw it on the quiz and it says mouth to mask for newborns. So I have no idea. I've never seen that. It wouldn't be on his New York State exam. The only time I ever saw a question about mouth to mask on a New York State exam, it said you were alone. Okay, so you're there by yourself and you have to ventilate a patient and ask you to pick which device would be best to ventilate the patient. Okay, and it had bag valve mask, it had pocket face mask. I think it had pocket face mask with oxygen, pocket face mask without oxygen. I think it had bag valve mask, and then it had that flow restricted device where you press the button and it forces the air into them. So The reason they would say the right answer on that, if you were alone, is that when you use a pocket face mask, you can take two hands and seal the mask on their face and then blow into them. So you have a 360-degree seal around the mask. If you were using the bag valve mask, you could only have one hand on the mask while the other hand is squeezing the bag valve mask. So they feel there's going to be a leak right on one side, where if you have a second person, they could hold a two-handed seal and then you just squeeze the bag valve mask. So that was the only time I ever saw a question. It was years and years and years ago, but that does bring up a good point. It's much easier to make a 360-degree seal on a pocket face mask because you don't have to use your hands for anything other than making the seal. There's no bag to squeeze or anything like that. Okay, again, we talked about infants being primary nose breathers. So again, there may be the need if their nose is all clogged up. I mean, we've all seen our kids when they had a bad runny nose and chest cold and stuff like that, how thick and and how hard it is for them to breathe through it. They're not going to like it while you're cleaning it, but they're going to like it afterwards. And it's not like it's going to be a one-time deal, right? I mean, you would have to either transport that child to the hospital, or if the parents don't want the kid to go to the hospital, you have to explain to them that they're going to have to continue to do that. Okay, again, we try to put the head in a neutral position when it's infants. So if we hyperextend it too far back, like we do with adults, or we let it flex forward, that can result in a closing of the airway. Okay, they don't recommend sticking your fingers in the mouth where you can't see and trying to see if there's anything you could feel, because they feel you could just push that. In other words, you may not see that piece of food or whatever and push it further down. Okay, so they don't recommend what they call blind finger sweeps, which is just shoving your fingers in the mouth and seeing if there's something you could hook, right? Like going down and like with a curve down their cheek and try to see if there's something you hook. They don't recommend that. And in general, we don't really stick our fingers in patients' mouths because there's always a bite risk and stuff like that. So again, it's just showing you the same thing that we kind of talked about, tongue taking up more room, trachea being soft, and so on that we just kind of discussed throughout the lecture. Now, I found these pictures. I thought they were pretty cool. So these are obviously cadavers, right? Dead people. And they're showing how the oral airway and how the nasal airway actually sit. So this is the actual tongue, okay? I mean, obviously this is a dried out, dead person, okay? But they're showing you actually how it sits. So an oral airway that fits right actually goes and kind of cups the tongue and keeps it up out of the way. So it's actually acting like a splint, okay? And it's not going so far. This structure right here is the epiglottis. So it's not going so far that it's actually obstructing the epiglottis. And we actually have a very good view of what they call the glottis, the top of the trachea. So you see the tube here? This tube actually comes through this bone and connects. It's called this is called your glottis, your larynx, right? So that when you swallow, what happens is that this whole structure actually moves up, okay, and kind of meets your epiglottis, right? So your epiglottis moves tiny bit downward, but it's more that if you ever watch somebody's neck when they swallow, it kind of looks like their throat is coming upward. And that what that does is it closes off the ability for food to go into your trachea, and then food just goes down this pipe, right? Because you're going to swallow, and food just goes down this pipe into your esophagus. This is your spinal column, okay? And this is your spinal cord. So here's your spinal column. Here's the back of your spinal column. Here's your spinal cord traveling through, okay? The darker parts are the vertebrae. The white parts are the discs between it that act like a shock absorber, okay? This is your brainstem, your foramen magnum, okay? These are all different parts of your brain, okay? And then here's your skull. You can't really see. You might be able to make out a tiny little bit of the dura mater, right? But you can't really see it too well. The other ones are too thin. You can't really see them. And this hole at the base of the skull, okay, that's called your foramen magnum. That's where your spinal cord comes in and connects with your medulla, okay? This is your nasopharynx, okay? It's kind of hard to see it, but that's your nasopharynx. That's all actually hollow, right? And it obviously comes down and connects into your oropharynx, okay? And then this is your laryngopharynx, and this is your esophagus, and this is your trachea, okay? And you can kind of make out a little bit of the cartilage that forms up the trachea. Okay, so anybody have any questions on the anatomy of what we were looking at? Okay, when we're talking about the occiput, the back of the skull, that's right back here, okay? These, you see there's like some hollow spots. those are your sinuses. So if you ever like flew in an airplane and you felt pain over there, these are air-filled cavities. And when the pressure changes and they expand, it can be excruciatingly painful and stuff like that. So those are your sinuses. Now, when the airway is too short or not put all the way in, you could see what's going to start happening is that the tongue is going to bulge down, okay, and again, this is a dried out tongue, so it's really not moving that far, but it's going to bulge down and push, okay, on the epiglottis and start to close off the airway. So that's the issue. And then the nasal airway, okay, coming through the nasopharynx, coming into the oropharynx. So when it's just right, it's sitting basically right pretty much where the epiglottis is, okay, maybe just a tiny little bit further, okay, and it's not going to stop the tongue from collapsing. Again, this tongue is not moving because the body's all dried out. It's not going to stop the tongue from collapsing, but it's going to give a pathway for the air to be able to get by. One thing I didn't point out before that I'll just show you now. So this is the roof of your mouth, right? Okay, so the from here to here is called your hard palate. So it's hard. Like if you stick your finger up into your mouth, pressing up towards the ceiling, it's hard. But as you go further back, this is called your soft palate. And this is where your gag reflex is. So this is when they're doing a strep test. This is what they're coming back and touching, and that's what makes you gag. The reason it has a gag reflex, okay, is that, the reason we say gag reflex, it's a protective mechanism, okay, that if things are too big, okay, and they're trying to get into your airway, it's going to cause you to gag and kind of force it out. So that's a protective kind of mechanism, okay. And then, okay, when it's too short, right, what's the problem? The tongue is going to come down, push the epiglottis, and seal off the airway. So it doesn't matter that you have this here because nothing will be able to get past it. So it's actually a pretty helpful. I really, to be honest with you, I should actually add it to the anatomy and physiology slides. Try to remember to do that. Okay. Where's your vagus nerve? You're not going to see it on this picture, but your vagus nerve would come from your brain. Okay. And there's holes in the base of your skull that let different nerves come out. I believe the vagus nerve, because it is in the back of your throat, so it does touch back here. That's why sometimes people, when they have strep tests and stuff, feel weak and dizzy and stuff, like they're going to faint, because if they overstimulate it, okay, they can actually stimulate the vagus nerve. But there's different holes that come out of the base, and those nerves travel, but they're tiny, right? The nerve basically fills up the whole hole. I mean, when we take the break, if I remember, I'll put up some pictures, and you can see what it looks like. I think they have pictures where you actually, can make it out and stuff like that. Okay, so here's a hard concept for people to think about. Okay, body surface area. So body surface area means the part of the, how much of the body you could see. So basically the skin. So it says larger than adults in proportion to body mass. So what does that mean? Obviously, a child doesn't have more skin than an adult does, but they're saying proportion. In other words, in comparison to the size of a child, there's actually more skin, which I always find hard to picture, but there's more surface area, okay, than there is in an adult. And this basically comes to play when we're talking about heat loss. Okay, so if there's more area of skin and the child is out in a cold environment, there's more area where they could lose heat through. And obviously the term for a low body temperature is called hypo, which means low, thermia, which means temperature. So kids out, okay, in the cold are more prone for two reasons. They have a large head, so we do lose a lot of heat through our head, okay, and then also because of this large skin, area, they can lose a lot of heat through it. Okay, they have less overall blood volume, obviously, than adults. Okay, but that's also, that's common sense. But I'm just saying, again, in proportion to the size of an adult, they actually have less blood, and they have no reserves of blood, or not the same reserves of blood we have as adults. So what it comes down to is that you may see a small I mean, I'm not talking a drop of blood, but you may see a smaller amount of blood that you really would not be so concerned about in an adult patient, but in a pediatric patient, it may be serious. Now, remember, one of the areas you see a lot of bleeding from in kids is scalp wounds, is hair, right? Scalp underneath the hair, just because kids hit their heads, fall, and stuff like that. And we said already that the scalp bleeds excessively because there's lots and lots of blood vessels to keep your brain warm. In other words, those blood vessels don't actually touch your brain, right? Because you have your skull in between it, but they kind of act as a temperature barrier to the cold outside air. So if you have a cut on that skin and lacerate those blood vessels, they can cause a lot of bleeding. It's very easy bleeding for the most part to control because you're pressing it right down onto the skull. Okay. But if the kid for some reason bleeds a lot before somebody takes care of it, they can actually, it can show more signs and symptoms than it would in an adult. Okay, so now, interacting or dealing with the pediatric patient. So obviously kids are going to be scared. They're going to be suspicious, okay, unless they have chronic health problems where they're in and out of the healthcare network a lot, then they're not as nervous and suspicious around people, that are in the healthcare because that's what they're used to doing. So, identify themselves, say hello to them, okay? If the parents are not present, let them know, okay, that you're calling the parents or you're in touch with the parents. You can let them talk to their parents. Now, the vast majority of times with kids, obviously, if we're able to talk to them, it's not like it's usually going to be a life-threatening problem. Okay, so the more nervous you seem, the more agitated you seem, the more nervous and agitated the child will get. Okay, if the child has some kind of comfort toy or something, that they like to hold, then obviously by all means let them hold it. If it's a very small child, okay, just be careful as far as like the buttons on a doll or the sometimes the eyes are sewn on. Like, in other words, if you're giving a kid something to hold, just make sure there's nothing they're going to choke on. Okay, don't tower over them, don't stand over them. Try to kneel down at their level and stuff like that. Obviously smiling helps. Okay, as long as it's not going to make the child crazy. Usually I'll say to them, is it okay if I hold your hand? I don't just reach out and grab it or anything like that. Okay. So now here's the kind of weird stuff, right? So let's say assessment stuff. So if you're going to use your stethoscope, you're going to lose your blood pressure cuff and stuff like that. Usually we'll tell them and explain it to them. Obviously, if your stethoscope was in your car and the head of your stethoscope is cold, you would want to warm it up before you put them on their chest, because if you make a child cry, you can no longer listen to lung sounds, right? All you're going to hear is them crying. So, explain. You could even let them hold it, let them play with it if you want and stuff like that. You could tell them the blood pressure cuff, like, don't say I'm going to take your pulse or take your blood pressure. They say that some small kids say take means take it away. So you could say, I'm going to listen to your blood pressure. I'm going to feel your pulse, however you want to say. I'm going to feel your wrist, because they probably don't know what pulse is. I'm going to feel your wrist. Okay. And the only thing I'll say with that is, and again, it's very rare you're ever going to do it on an EMT level, but let's say you had kids having a severe allergic reaction and you're going to use the EpiPen. Okay. So one, if they have a history of severe allergic reactions, they probably know all about the EpiPen. Okay. Two, if they don't have a history and this is the first time they're going to do it, okay, you don't have to go into this whole big detailed explanation, because once you say, I'm going to give you a shot, you remember when you were a kid and you were going to the pediatrician, right? The whole time you were there, you were just wondering if you're going to get a shot, right? I mean, it's like that was the whole, you didn't hear anything else other just waiting to see if they're coming in with a needle and you were going to get a shot. So it's the same thing. So if you have to give a child, let's say you have to use the EpiPen. So you just do it. In other words, you don't discuss it. You don't, tell them, oh, we're going to try to make it not hurt or anything like that. You just go and do it. Okay. So and just get it over with. And you don't have to have a whole long detailed discussion. Remember, you don't have to have consent to treat a child. It's implied consent. You have to have consent from the parents if they're present, but you don't have to have this whole discussion with the parents. And I wouldn't even discuss it in front of the child if you're discussing it with the parents. Taking them outside and say, it seems like he's having, obviously you could see it. It seems like he's having a severe allergic reaction. We're going to have to give him a shot of epinephrine. Is that okay? Yes, fine. And then you just go and do it. You don't have a big drawn out discussion with the kid or anything like that. Okay. Letting your child see your face obviously is a little difficult now in the COVID environment because we have masks and stuff like that, but I don't see how else the child wouldn't see your face. Okay. And then, we tend to be working pretty quickly when you do things. So, either assign somebody who's not involved in actually doing any skills to stay with the child and explain things to the child, or you have to, periodically just, stop for a second what you're doing and talk to the kid and stuff like that. Don't lie to the child. In other words, if you're giving them a shot of epinephrine, don't say, "Oh, we're going to give you an injection, but it's not going to hurt," because obviously all needles hurt, stuff like that. Or if you're going to be splinting a broken leg, okay, don't tell them it's not going to hurt, because it is going to hurt, because you're moving a broken bone. Okay, supporting the parents and other caregivers, right? So the parents are going to be very nervous. So they're going to need some management. Okay. And again, if there's anybody else around. Now, there are some parents, especially parents of kids who have chronic medical conditions, that can be a big asset, which means, they typically know everything there is to know about their child's condition. They may have equipment in the house to manage your child's condition. So they may actually be a big help to you. The problem is that a lot of parents of kids who have health problems assume we know everything about the child's health problem. Okay. So you'll go into houses and they're going to tell you all these strange, diagnoses and stuff like that. And you have to just be honest with them and say, listen, I would appreciate, I don't know much about your child's condition. And then whatever you want to do to educate me so I can help, feel free to. And then let them explain and say, look, we don't have this very often. So you just have to guide me in what's best. We're going to take your child, to the hospital that best can care for them and stuff like that. That may mean you may be not going inside the county. You may be having to transport to a pediatric hospital. But, I wouldn't lie to them and pretend like you know all this stuff, because I'll be honest with you, there's conditions out there I don't even know. The other day I went to a kid's house and she was rattling off of these diagnoses and everything. And I said, ma'am, I said, let's just make sure there's nothing serious going on, and then you could go and tell me about all the other problems your child has. But I said, first, let me just get a set of vital signs, put them on a pulse ox, make sure everything's okay like that, and then we'll go over everything else, and you could, explain to me. Okay. And they may even, like, let's say the kid has a trach, right? Has an artificial opening into his trachea. They may know better how to suction it than you ever would. So, and they probably have done it a million times. So if it's at the point where you think the kid's trachea needs to be suctioned, one, the mother would probably know whether or not it needs to, or the father. And two, they're probably better at doing it than you would be. So there's no harm in having them help you, in treating the child and stuff like that. Okay. So when we talk about the assessment, somebody invented this thing they call the pediatric assessment triangle, right? So there's 3 legs to it. So we'll talk about that. One's airway, one's circulation, one's breathing, right? So it's the 3 legs that we always do. Okay. So there's always what they call the doorway assessment. So in COVID, the doorway assessment is like to make sure it's safe for us to be there, right? So we don't want to enter a room, okay, till we know what's going on. Nowadays, since we're always wearing PPE, it doesn't really matter too much. But in the beginning, when we were putting PPE on for every patient, we'd want to know what's going on before we entered a room without PPE. And we also used to pass in a mask for them to put on. So now most patients, you'll find are wearing masks when you walk into the house, at least outside of the, the Jewish world. It's getting better in the Jewish world, but you'll see, a lot of patients, when they call you, they actually have masks on and stuff like that. So the first one, again, from the doorway was more or less to just get a global picture of what's going on. And then the rest of the assessment obviously is done when you're right next to the patient. So appearance means that we're looking at how they look. Do they look like they're well cared for? In other words, are they clean? Do they look like they're fed? And, do they look like they're having any real serious trouble breathing, anything like that? Okay. We're going to assess their capillary refill. Okay. Look at their skin color, temperature, moisture, just to get a quick idea of their perfusion. All kind of common sense stuff that, you've probably been talking about when you do skills and stuff like that. So this is the pediatric assessment triangle. So appearance, breathing, circulation. Right. Sorry, oops. I couldn't hear. Okay, now, how do you assess their mental status, right? So this is a little difficult in a child that maybe doesn't talk. So the first thing is their parents should have an idea, okay, if their parents are present or their caregiver, mentally how they are, right? So you could say to them, is this how they normally, react, how they interact with you? Do they seem like they're 100%? So that would be the first thing you could do. The other thing is we always kind of look at how they respond to us. So a kid should be a little concerned about the strange person, being around them. So they should kind of be watching you and maybe a little, leery or apprehensive about you being there. So if they're just kind of totally not paying attention, not with it and stuff like that, we would always kind of want to ask the parents, is this kind of how they are? Where they're not really concerned that we're here and they're not really following what's going on. And, you have to be guided by what the parents tell you. Say, yeah, it's an easygoing kid. That's how they always are. then it's probably not a problem. But if they say to you, no, they're definitely not reacting normally and stuff like that. Okay. Tone and body position means, do they have good muscle tone? Are they able to hold themselves up? Okay. Or they look like they're flopping over. Work of breathing. So does it look like they're able to breathe without any trouble? Okay. What's the quality of their cry or their speech? So is it a nice, loud, screaming cry? Probably tells you there's no real problem with the airway. Okay. And again, skin color. Now remember, on kids, it's not uncommon for their extremities, right, to be paler than their center of their body, than their core, right? We say the core is the center of the body. And that's just, the further you away are from the heart, the less blood. So it's just not uncommon for them, to be a little pale on their extremities, especially if they're cold. Okay, mental status, we're still doing alert, verbal, painful, right? AV, AVPU. Okay, so unresponsive is the last one, AVPU. Okay, and then obviously if they're unresponsive, we try to do some type of what we call painful stimuli. But on a small child, we're not getting crazy because we don't want to hurt them or anything like that. So it may just be some gentle taps on the feet or something like that. Okay, airway. Okay, is the airway open? Okay, is it going to stay open? Is there anything that's going to endanger it? Endanger it means, is there anything that could be closing it off? Okay, head in a neutral position so we don't hyperextend. Okay, we're looking at the chest. Is the chest rising and falling equally and fully? Okay, do they look like they're struggling to breathe? Are there any abnormal breath sounds? How fast are they breathing? Obviously, I think at this point, everybody knows that the respiratory rate and the heart rate in a pediatric patient is much faster than an adult because they have to bring in more oxygen and circulate it. And the body is just kind of in the process of growing and maturing and stuff like that. Okay, and then their skin color, if they're light skin Caucasian, are they pink? Are they pale? And so on. Okay, so again, we expect to see warm pink, dry skin. That's normal. We expect to have nice normal pulses. Okay, and capillary refill of less than 2 seconds. Okay, and stuff like that. Okay, and then obviously if there's any bleeding, we need to control it. And everything that you learned so far for the adult patient goes for bleeding control in the pediatric patient. So, if you can't control it with direct pressure and hemostatic gauze, you would have to go to a tourniquet. So they're showing you capillary refill over here. Now, I know you may have thought capillary refill is something like always on the fingernails, but you have capillaries over every square inch of your body. Okay, so you can just push on the hand. You can push on the palm of the hand. You can push on the top of the hand. It doesn't really matter. Same thing on the feet. You just want to hold it down for a couple seconds. That's pushing the blood out of capillary. Then you lift your finger off and you want to see that the skin underneath it turns pink, because right now, obviously it's pale, turns pink, okay, within 2 seconds. And 2 seconds is a long time. Now, interestingly, you see how pink the fingers are, because when he's putting pressure here, he's not letting the blood, right, go back up. So he's got a lot of blood stuck in the fingers. So it will appear pinker more distal to where you're pressing, right? So more further away, more distal, it will appear pink because nothing can get back up. None of the venous blood can get back up. But as soon as he takes his finger off, then this is going to turn pink. Hopefully there's no problem with the kid. I mean, the rest of him looks pink, so I don't think there's going to be a problem. He's going to turn pink, and then that extra blood down there will drain out. Okay. What is the blood pressure and respirations on a child? So there is a chart in your book, but I will send out, I found on the internet like a year ago, a very good chart on normal pediatric vital signs. I may have to take a break to get a drink. The thing you have to remember is they're putting on the chart somewhat normal vital signs. We don't really go to kids unless there's a problem. So it's not common for us to find kids, especially if they were crying or they're sick or something like that, that's going to have normal vital signs. But it's a good idea just to know, like we talked the other night, a newborn, we're expecting their heart rate to be somewhere around 150, 160, their respiratory rate to be 40 to 60. If I didn't tell you that and you walked in and saw a newborn baby breathing 60 times a minute, you might say, whoa, the fastest Frank ever said was 20. This kid's breathing 3 times faster. So it's got to be something wrong. But actually in a kid, we said with the baby, we're more concerned if it starts going slower than if it's going faster. Okay. So I will send it out to you, but it's numbers that would be a range of normal. So if it's outside the range, it would be considered abnormal. But just remember, most of the times we go to a pediatric patient, it's not because they're healthy and the parents are just calling us, right? There's some kind of emergency. Again, in the Jewish world, you do go to more pediatric calls just because obviously there's more pediatric kids. And you do go to a lot of pediatric calls that are nonsense, right? Like kid has a minor cut, kid has a tick, kid has this, because that doesn't really happen in a non-Jewish world. They would, they wouldn't call you. They, if there was a tick, they go to the doctor. If there's a little cut, they would go to the doctor. They wouldn't call 911 to have the ambulance come. So you may go on calls where the kid is not in a real emergency. Okay. So, you may see kids then in the normal vital sign range and stuff like that. Okay. So priority patients are patients that we're concerned about, right? So when they say poor general impression, means you walk in the house and say, oh my God, this kid doesn't look good. Okay. They're unresponsive to you. Listless means that they're awake, but they have no energy. They're just kind of laying there. Like listless would be when you see your kid sick, really, really sick, and you feel horrible and they're just laying there and they have no energy. That's kind of listless. Okay. That they do not recognize their parents or caregiver, right? So their mental status is diminished. Okay. Again, patients who are having airway problems, maybe have stridor. We'll talk about the different sounds, right? Remember we said with stridor is an upper airway sound caused by when the larynx starts to close off start to tighten and close off the upper airway. Patients that are either not breathing or having trouble breathing. Any stories of shock? Can anybody want to tell me what they think one of the more common causes of shock in pediatric patients is? What type of shock? Anybody have any ideas in pediatric patients? So think of your own kids. Okay, so what's the most common thing you see happen with your kids that could lead them to get dehydrated, shocky, something like that? What does somebody think?
Psychogenic?
Psychogenic fainting? I don't know.
Crying too much?
Nah, again, it's very hard to get dehydrated by crying too much, but you're getting closer. What do kids get? Okay, you probably all had this. You're just not thinking of it.
Diarrhea.
Very good. Vomiting and diarrhea. Okay. So, I mean, none of us have had kids, right, who have not gone through an episode of bad vomiting and diarrhea. Because they don't have extra fluid, it is possible for them, okay, to get fairly dehydrated. Okay. So that would be what form of shock? What's the category, right? We have a couple different categories: cardiogenic, distributive, obstructive.
Distributive.
Not distributive. Distributive is when the blood vessels vasodilate, right? That's sepsis, neurogenic.
Hemovolemic shock.
Hypovolemic. Very good. So then hypovolemic has two. Hypovolemic has two categories, okay? And it has hemorrhagic, which is blood loss, and it has non-blood loss. So this vomiting and diarrhea is the non-blood loss. So they call it either metabolic or hypovolemic shock. Okay. So just again, because we weren't so quick on the shock answers, and I know the shock is one of the harder things to answer. Oh, actually, Mendel, you did put up metabolic. Very good. Okay. Just to go through the different categories real quick, right? So we have cardiogenic shock, when the problem is either with the heart's ability to pump. That's more in adults who've had heart attacks, or maybe infection damaging their heart, or the valves between the chambers of the heart, okay, are not working properly. So that's pretty rare. Okay, then we have the distributive shocks, which are the confusing ones. Those are the neurogenic, where there's spinal cord injury, the sepsis, where there's an infection, the psychogenic, where there's fainting, and the anaphylaxis, okay, where there's vasodilation, So all of those shocks, sepsis, neurogenic, vasovagal, fainting, right, syncope, and anaphylaxis. The shock is not caused by fluid loss; it's caused by sudden, very large vasodilation. So the size of the inside of the blood tubes, okay, gets too big and the pressure falls. Okay, so that's all those. So sepsis, out of those, the most common cause of distributive shock would be sepsis, okay, in a kid, an infection. And then we had obstructive shock, where there's a blockage of the blood, and we said that's a pulmonary embolism. What else did we say? Tension pneumothorax. Just trying to think if there's anything else. I'm a little tired tonight. And then we had so we did distributive, we did cardiogenic, we did obstructive, and then we have the hypovolemic, right? And under hypovolemic, there's two divisions. There's the blood loss one, which is hemorrhagic, right? And then there's the non-fluid other than. So the biggest one we see in kids is the vomiting and diarrhea. The other thing you could see is they technically would put that also with burns when they lose plasma through the burn. They'd have it under the non-hemorrhagic, the metabolic or non-hemorrhagic hypovolemic shock. And then if you remember from diabetic ketoacidosis, which is the high blood sugar emergency, one of the things that happens is we said they urinate a lot to try to get rid of all the extra sugar. So when they're urinating a lot, okay, they're actually dehydrating themselves. So a kid who has diabetic ketoacidosis can also become dehydrated. And again, it's not blood loss, it's fluid other than blood. Okay, and then again, uncontrolled bleeding and stuff like that. And remember, we said kids do not tolerate blood loss very well, so we have to be, very aggressive in treating that. Okay. Now, secondary assessment-wise, well, first thing I want to point out is that there is really no safe way in transporting a pediatric patient in an ambulance. Okay. So you see here, they actually have a stretcher on top of a stretcher. So this kid is on the ambulance stretcher, but there's actually a device that you strap to the ambulance stretcher, and then it has straps that fit a child-sized body better. And that's really the only safe way to transport a kid on a stretcher. And most of the ambulances do have this. Sometimes in the captain's seat, which is the chair, in front of the stretcher over here, there's basically the back of it that you would be pressing your back pulls down. Okay. And inside there's a harness system. So the kid would actually be sitting on the seat that flops down. So he's up a couple inches. And then there's a separate harness system that's more geared towards, a pediatric size chest. Okay. They say with kids that instead of doing what we usually do, which is a head to toe survey, which means we start at the head and work our way down, that it's less threatening, less scary for them if we start at their feet and work their way up towards their head. Okay. So I don't know that it really is, but that's typically a test question that on adults you do from the top to the bottom. Okay, kids you do from the bottom to the top. Okay. When you're examining a child, if it's safe for the child to be not in the ambulance, but I'm saying when you're just examining a child, if it's more comfortable and safe for the child to be held by the parent, you could always do that. Okay, if you have to remove any clothing or loosen any clothing, then obviously cover them up as soon as you can. Okay, and then you just tell them, I'm just lifting your shirt to make sure you don't have any injuries or any boo-boos, right, on your chest. I don't know how you say it in Yiddish, but that there's nothing hurt, okay, somewhere. Okay. Obviously, if they're under the age of 1, those fontanelles can still be soft, so you don't want to put any pressure where they are. Okay. Meningitis, we'll talk about when we talk about emergencies, but that's an infection in the lining of the brain and the spinal cord. Okay. And we said also closed head trauma rising into cranial pressure can cause the fontanelles to bulge outward, right? So they kind of go outward. Okay. And then if they're sloped inward, they're curved inward, going down more towards the brain, that could be a sign of dehydration. And obviously, any kind of head trauma, okay, can lead you to have the head, the closed head injury rising into cranial pressure. Nose and the ears, really, most of the times, there's not much we're going to do with the ears. But again, if you suspected a child to have a basilar skull fracture, just like you would with the adult patient, okay, you're going to look for either blood or cerebrospinal fluid leaking from the nose or the ears, okay? And just to remember, okay, that kids whose noses are clogged are going to have more trouble breathing. I'm sure some of you have kids that are very chronic nose bleeders, okay, so their noses bleed a lot and stuff like that. One of the things you could try is to put a humidifier in their bedroom at night, especially if you have a forced air heating system. It tends to dry everything out. But to put a humidifier, it doesn't have to be a steamy humidifier, just something putting a little moisture in the air, and that may actually help, with the drying out. They also sell these different saline sprays that help dry it out, because most nosebleeds are just that the capillaries are dried and they just become a little more fragile and easier to rupture. Okay. Oxygen. So it's very scary for a small patient to have an oxygen mask on their face. So it's acceptable on smaller patients, right? We don't want to make them cry because they're going to have more trouble breathing. It's acceptable on smaller patients to use blow-by oxygen, where you would just take the tubing or maybe just hold the oxygen mask in the general vicinity of their face without pressing it on them and stuff like that. Okay. 1 second. Okay. So again, muscles being weaker, you have this big head on a very fragile neck. So you have to always be supporting the head whenever you're moving the patient and stuff like that. And again, we said that in proportion to the size of their body, their heads tend to be larger and heavier than adults are. They're not obviously larger and heavier than my head is, but in proportion to the size of their body, tends to be heavier, and they tend to lean forward and stuff like that. Okay. Again, the muscles and bones are less developed, so it's more likely to have a problem. Okay. And when we talk about meningitis, we're going to see that one of the signs, right, if the meninges, the lining of the spinal cord is swollen, one of the signs is that they get such a stiff neck that they can't bring their chin to their chest. Okay. So when you find them, they're actually looking straight forward, and they're probably complaining of a sore neck and a headache, and a fever, right? And that's always rule out meningitis until proven otherwise. So this is showing you positioning the child, okay, to make up for that exaggerated occiput, right? That exaggerated base of the skull by putting some padding, okay, underneath their shoulders and back to build them up into that same position. So that's the actual same kid that we were looking at in the beginning of class. Now his head is in a neutral position. It's not flexed forward like it was in the beginning of class and stuff like that. What time is it? Okay, so we'll get a break in a couple of minutes. Okay, again, for the most times, depending on the book, most of the times infants we say in a neutral position, kids in a sniffing position. So neutral means no movement, right? Their head is, well, this would be a neutral position, right? Sniffing, when you sniff, right, you just lift your head a tiny little bit. So you're not hyperextending it, you're just opening it tiny little bit. So infants typically neutral, kids in a sniffing position. Okay. Again, the padding under the shoulders. Okay, chest. So lung sounds we'll talk about. Okay, we want to listen. Wheezing is more like the asthma patient and stuff like that. Symmetry is the term that the chest looks equal and is rising and falling equally, right? So we expect that when somebody breathes, both lungs inflate and the chest rises and falls equally. We're going to look for any trauma. Paradoxical motion means that when the chest rises, the entire chest rises, okay? If you were to see a piece go in the opposite direction, so like most of the chest wall goes out, but one or two pieces goes inward, that's a sign, if you remember when we did chest trauma, something called a flail chest, where at least 2 to 3 or more ribs are broken in more than 2 or 3 spots. So that section of rib is free from the rest of the rib cage. And what tends to happen is that it actually moves opposite. So when you're breathing in and your chest wall is going out, that piece kind of stays in place. So it looks like it's actually going inward. It's very rare, but it would be a sign of somebody who has significant chest trauma. You could have what's called intercostal retractions. This is typical when kids have stridor and it's hard for them to breathe in. So they're sucking so hard that you can see the muscles between their ribs actually pulling inward. So that would never be normal in a patient. So if you see retractions, you could see where the xiphoid area starts to cave in, again, because they're having trouble sucking air in. So none of these would be normal findings in a pediatric patient, okay? Again, we're always concerned if over the stomach is hard, although if a kid cries a lot and gets a lot of air in their stomach, you could see their stomach actually bulging and it would be hard. But again, if you suspect abdominal trauma, trauma to the abdominal cavity, and it's rigid, that always possibly could be a sign of bleeding inside. Okay. And again, if the abdomen, if your stomach isn't overly inflated with air or anything like that, it's going to press up on the diaphragm. It's going to make it a little harder to breathe. Pelvis bone, the hip bones and stuff like that. Again, not so common for kids to have hip fractures, but just like when you learned your assessment, you're kind of gently touching in that area to see if there's any pain. And in every extremity, we want to check capillary refill. Okay, so the feet will probably not be as good as the hands. Okay, but ideally it should be less than 2 seconds. We're going to check for the presence of distal pulses. Okay, and we do the same thing. Is there a pulse? Can they move it? That's motor. And do they feel which finger you're touching in every extremity? I'll go on and we'll just do a couple more. Okay, opening an airway, right? So again, the common way of opening an airway, head, tilt, chin lift, but again, just neutral position on a infant and sniffing position on a child. Okay, you can still try the jaw thrust if you suspect there being spinal issues, but it usually doesn't work. So if you can't open the airway, even if you suspect spinal injuries, which is very rare, you would still do the head, tilt, chin lift. Suctioning, we know, is limited, right? So in adults, we do 15 seconds. On a child, we do 10 seconds. On an infant, we do 5 seconds. And that's for 2 reasons. Obviously, when you're suctioning someone, you're not ventilating them and you're pulling air out of them. The other thing was, if you remember those pictures that we looked at with the oral airway and nasal airway, and I showed you the hard palate and the soft palate, remember I said that the vagus nerve comes down in that area. Okay, so if you're overly aggressive with suctioning, you can actually cause them to have a vasovagal response and slow their heart rate and drop their blood pressure and stuff like that. And again, because the tongue fills up a lot of their airway, okay, and it's a weak muscle because of the fact that they're young kids, it is possible to have an airway obstruction. This is showing you the way they would recommend putting an oral airway in a pediatric patient, where you would actually hold the tongue up out of the way with the tongue depressor and just insert it actually the way it winds up sitting in the mouth. We know with adults, we actually put it in backwards and corkscrew it down, but this is what they would recommend with kids. I don't know if it's just the angle of the picture, but that does seem like an exceptionally large oral airway in that very small child. So I don't know if it's a, picture problem, or that was the size they had available when they were doing the picture. Okay, again, nasal airways measured the same exact way. Okay, so you're going to go from the nostril to the ear, and it should line up that basically you're beyond the tongue, okay, and right in front of the opening to the trachea. Okay, if it's too long of a nasal airway, it'll continue down. It won't curve up. Okay, it'll continue down this way, and it'll be blowing air in your esophagus. So that's obviously not good. Okay, airway obstructions, again, partial obstructions means that the child can still do something to clear it. They can cough or something like that. Okay, so we try to make them comfortable. We put them on oxygen, we transport, encourage them to cough. If it's a complete obstruction, then you know that if it's a child under 1 year of age, you do 5 back blows and 5 chest thrusts, and you continue doing that to either the object comes out or the child becomes unresponsive. If the child becomes unresponsive, you start CPR. If you happen to deliver your full 30 compressions of CPR, okay, then you would look in the mouth and see if there's anything you can remove before you go back to your next set of 30. Remember, in this case, we're not doing CPR to circulate blood because this kid is probably not in cardiac arrest. They're just in respiratory arrest because they have an airway blockage. Okay, we're doing it to compress the sternum onto the lungs and blow out the obstruction, just like when we're doing the Heimlich and everything like that. If they're over 1 year of age, okay, then you could do the Heimlich maneuver or abdominal thrust, whatever you want to call it. But the strength that you would have to use, the force and stuff, obviously on these small kids would be a lot less. And then whenever you're doing abdominal thrusts, whether it be on a child over 1 year of age or an adult, you continue doing those to either the object that comes out or the child would become unresponsive. So there's no numbers like there are with the back blows and chest thrusts. Okay, but if the child does at some point start getting weak because you're not clearing and the oxygen level is falling, then you would also put that kid's supine and start CPR. Okay, this is just showing you some of the different signs or different things that you could possibly have in kids. So this is, I don't know if you can make out what this is over here. This is a very interesting case. So, have you ever tried to assemble some of these like cheap furniture you buy in stores, and they have these little wooden dowels that you fit in all the holes, you put a little glue in, and you press the other piece of wood together, and it kind of helps hold everything from moving. So this was a kid that was helping his father assemble a desk, a cheap desk from Walmart or something like that. And so he was, the father had him handing him the screws and handing him all the different pieces and stuff. And the kid became short of breath. Okay. And they took him to the pediatrician. The pediatrician somehow decided he was starting to have a pneumonia, and sent him for a chest x-ray. Now the kid had no history of being sick. I don't know where the pediatrician came up with a pneumonia, but decided to send him for a chest x-ray. When they did a chest x-ray, they actually saw that he aspirated one of these dowels into his right medstem bronchi. So you see the trachea, right? It comes to about here, and then it splits. You can almost make out the tubes. They split into the two bronchi, and we said that anatomically it's more likely for things to go in the right medstem just because it tends to drop more straight down, where this one curves more like this. So you see the trachea coming down, okay, and then it curves, and that's it right there in the bronchi. And so he's basically probably obstructing, just judging from the size of his bronchi. It looks like it's pretty much, sealing it. It looks like it's 100%. So, that's an issue. This is his sac of his heart, right, all over here, and then his lungs. The blacked out area is his lungs. Okay. This is his liver. That's his stomach. Again, because his stomach is hollow, and it probably looks like there's some air in it. Okay. It kind of appears like this. So that's what you have there. Okay, so that's a pretty interesting. And all this means radio opaque means that it's something that the X-ray can pick up, right? There's certain things that are not radio opaque, which means that you wouldn't actually see it on an X-ray. Okay. And when we go through the signs of the different emergencies, I'll show you what happens with the airways and stuff like that. Okay, so again, on pediatric patients, okay, the back blows, chest thrusts, okay, under 1 year of age, okay. Supplemental oxygen, again, as long as it's not going to make the kid upset, you could try to put a mask on them, but most of the times it's blow by oxygen. And this is just talking about one of the things supposedly, you know, helps is you take your pen or pencil, you take a wood, not a wooden, a paper cup, and you punch a hole through the bottom of the paper cup, okay, and you stick the oxygen tubing into that, and then you tell the kid to hold the cup and look at it. So it's a way of you know, giving them some blow by oxygen. But again, if they're going to be upset or anything like that, and it's going to make them cry, you know, just hold the oxygen, you know, not blowing directly on them, but in the general vicinity. So it's increasing the amount of oxygen in the air they're breathing in and stuff like that. Okay. Again, we have to watch our volumes when we're ventilating kids. Remember, it's don't ever think that you have to ventilate as much as an adult. And again, it's our sign that we're delivering adequate ventilations is we just start to see the chest rise. As soon as we start to see the chest rise, we have enough air. Okay, you have to have multiple size masks to make sure you have a mask that will fit on the child's face. Okay, the flow restricted oxygen powered ventilation devices that I told you we never use, which is the one where you press a button and it forces air in. We don't use those on kids, okay, because it's just too much pressure and stuff like that. If you're ventilating a kid and you don't see chest rise, a couple things you could consider. You may not have the airway open enough, right? So you may have to open up the airway a little more. It could be that there's a foreign body airway obstruction that nobody pointed out to you or told you, okay? Remember, if it's a bag valve mask with the pop-off valves and you can't get chest rise, you may have to shut off the pop-off valve so that whatever you squeeze goes into the patient, okay? But then you have to be careful that you don't overventilate. And they did show you the pop-off valves on Sunday on the bag valve mask, right? I asked them to. They show you how to, where the pop-off valves and everything and how to shut them off?
Yes.
Okay, perfect. Okay, again, blow by oxygen is acceptable. A mask, obviously, you know, should basically be going from the bridge of the nose, okay, to this little groove over here. Let's take a break, okay, because now we're going to get into shock. So it is 9:03. Come back about 9:15, and we'll pick up. Okay, so just take a quick break, and remind me to start the recording again. Left off that we're going to go into now, talking a little more about shock. So let's just go through these different examples of shock and see if we can categorize the categories they go in. So diarrhea or vomiting, we said would be the hypovolemic shock. And if you wanted to be totally accurate, it would be the metabolic form of hypovolemic shock. Infection would be sepsis, which would be under distributive shock caused by vasodilation. The diarrhea and vomiting would be fluid loss other than blood. Trauma or blood loss would be hemorrhagic shock, okay, which again is under hypovolemic. So hypovolemic is the top, and then there's two divisions, hemorrhagic, which is blood loss, and then the fluid other than blood, which would be metabolic. Sometimes in a textbook, they just call it hypovolemic. They don't say metabolic. Allergic reactions like anaphylaxis would be a form of distributive shock, okay, because of the vasodilation. Poisonings would be a little hard to pinpoint because there's so many different things. I don't know. I mean, some could work on the heart, some could work on the blood vessels. So I don't know what they would really get at here. And then cardiac events would be the cardiogenic shock. Okay, so those are the different categories that we're talking there. Okay, so again, what do? There's not much we can do for any of the shocks with the exception of anaphylaxis, right? In anaphylaxis, we have epinephrine, but other than that, it's basically going to be keep them warm. If it's external bleeding, we're going to try to stop it, okay? Put them on high concentration oxygen and transport them. There's not really much, you know, with the exception of anaphylaxis that we could do. Obviously, if it's severe external bleeding, we could try direct pressure with hemostatic gauze and tourniquets, but, you know, there's not a lot we're going to do. Okay, medical emergencies. So the most common reason kids run into problems is breathing problems, right? So that's the number one cause that kids are going to have. Hypoxia is the biggest issue. When a child becomes hypoxic, their oxygen level drops, okay? It's going to probably cause bradycardia because the heart is not getting enough fuel, enough oxygen. And once the heart rate starts to drop, then the blood pressure drops and it becomes a very, you know, vicious pathway towards death in a kid. So the way we manage it is to keep them from becoming, hypoxic. Okay, so it's more likely, to be the problem, and it's the most likely reason why a kid goes into cardiac arrest, right? Like kids don't have primary VFib, right? They don't have like adults where they have diseased hearts because they're young. So the reason that kids run into problems would be because of a breathing problem. Okay, so we're going to talk about how we determine whether it's an upper or lower airway problem, because if it's lower, we do have albuterol to be able to treat them. If it's upper, there's not much we can do except transport them. Okay, and we'll talk about what we do in both of those situations. We already talked a little bit about respiratory failure in some of the previous sections. Okay, so it can range, obviously trouble breathing can range from a kid who has a cold, right, stuffed nose, okay, to kids who have life-threatening problems like epiglottitis or RSV, and we're going to talk about all those different things. And most of the times, again, we're not going to stay in the house and make these kids better. We're going to do what we can do while we're heading to the hospital. There's never probably going to be a situation where we're going to make them 100% better. Okay, so we're going to differentiate again between upper airway. So upper airway would be the larynx, lower airway would be the bronchioles. Okay, so again, oops, I went past it. I'm sorry. Here's upper airway. So upper airway would be problems with the mouth, the throat, and the larynx, right? The top of the trachea. So what could we have? So in the throat or the mouth, probably not too much, probably trauma, bleeding, and stuff like that, loose teeth. Throat, okay, foreign body airway obstructions, infections, trauma, swelling, and stuff like that, okay? The most common abnormal upper respiratory sound, upper airway sound that you're going to hear is stridor. And stridor is a prolonged inspiratory sound. So it's going to take them a long time to breathe on the way in. So it's like a, so it's definitely, you can hear without a stethoscope, okay? And we'll talk about now some of the reasons why kids would have those issues in a couple seconds, okay? Lower airway, okay, is going to affect either the bronchioles, okay, right before the alveoli or the alveoli itself. So that's more like your asthma patients, your pneumonia patients, and stuff like that. Okay, and we'll talk about those and the sounds and everything they make. Now, when we have kids who are having trouble breathing, what are we going to see? So nasal flaring means that when they're breathing in, okay, because they're sucking air with such force, their nostrils, the skin over here on the side of their nose actually goes outward. Retractions were like those pictures I showed you where you saw the muscles between their ribs, their intercostal muscles actually pulling in. The abdominal muscle tugging is when you saw that like kind of xiphoid process kind of caving in. Stridor again is that high-pitched, very prolonged inspiratory sound when people have problems with their larynx. Wheezing is the lower airway whistling sound, okay? And grunting is a little hard. I mean, grunting is another sound that kids make. I've never heard it in an emergency setting, in my time doing this, but it'd be kind of like a type of breathing like that, when they're breathing. And again, that's just another sound that they can make when they're having trouble breathing. Okay, respiratory rate's too fast. So technically too fast would be over 60 breaths per minute. Children whose mental statuses are starting to decrease, okay, because they're getting hypoxic. Respiratory patterns that are too slow, okay, or very irregular. Cyanosis obviously is always a sign of trouble breathing, but a very late sign. Okay, decreased muscle tone means that because they're so hypoxic, they can't hold themselves up. They're just kind of limp. Okay, and then again, since the heart is not getting enough oxygen when they're hypoxic, their heart is not going to beat well, so they're going to start having weaker distal pulses, okay, delayed capillary fill, and so on. And then, since the heart needs oxygen as its fuel, right, oxygen and sugar as its fuel to be able to pump or beat, it's not going to be able to sustain those fast rates that are normal in kids, so you're going to start seeing bradycardia when kids become hypoxic. So the first one we're going to talk about is a condition called croup. Okay, some of you may have kids who are prone to croup. Croup is a viral infection. It's not a bacterial infection. It's a viral infection, so there's no antibiotics to take. Sometimes kids get both croup and a bacterial infection, but most of the times it's a viral infection. Usually presents in the wintertime, okay? And they present with a barking-like cough, okay? So most of the times during the daytime, they're okay. They may have a mild fever, but there are no real problems. It's usually at night where they develop this very like type of cough. And a lot of times they go to sleep fine and the parents wake up to the sound of the kid, coughing like that. So the first times it happens, obviously it's very scary to the kid and it's very, very scary to the parents. And they don't know what to do. So they obviously call for help, okay? It's very rare, okay, when kids who have croup, okay, get emergent, get very, very sick. But if they have underlying medical problems, it's more likely for them to, get very sick. So croup a lot of times can be dealt with without medications. They need cool air. A cool, moist air is best. Okay, so like making the room too hot would be worse for a croupy kid. So sometimes there's some kids, the parents may bring them outside on like the back deck, put a coat on them and stuff like that, because you just want them to breathe in the cool air. You don't want them to get cold themselves. Or maybe sit them right outside the door and let them breathe in that cool night air. Some parents have prescriptions for steroid medications that the kids take to help reduce the swelling. If you're going to put them in the bathroom by the shower, you don't put them in the shower, but you put them right outside the shower. And a lot of times people make the bathroom all hot and steamy, but really cool. So putting the shower on cold and having cool, moist air reduces swelling. Warm air makes more swelling, right? If you take a hot bath, you see your blood vessels all relax and bring blood out to the surface. So hot, moist air does not work as effectively as cool, moist air in croup, right? Because croup, you want cold to reduce swelling. Cold always reduces swelling. So really, for the vast majority of croupy kids, they don't really need a lot of treatment. They just need to breathe in cool, moist air. That usually will do a good job in kind of making them better. Now, what happens in croup is they get a swelling right up at the top of their larynx. So if you were to look, let's look at this one. So here's the trachea, right? This is towards the bottom. Here's a trachea coming up the neck towards the mouth. And right before, okay, it gets up into the mouth, okay, where the larynx is, where the big piece of cartilage is right here, you see how it starts to narrow? And that's called the steeple sign. A steeple is, if you ever see a church, they have that tower and it narrows. So a tower comes and it narrows towards the top. And the base thing, the same thing is happening with this kid, is that the trachea should be the same diameter all the way down. But when they have croup, they get swelling from the infection, from the viral infection. And the barking sound, sound that you hear is them actually forcing open the air, forcing the air through this narrowed opening and making that barking sound. So, I mean, you don't need to know steeple sign. You don't need to know any of that. Okay, but that's, if you ever hear them say, this is what they would do as far as diagnosis. They take a soft tissue x-ray of the neck and they would see that. Most of the times they don't even bother. Why expose the kid to radiation? So if it's a kid known to have croup or anything like that, they just really give them warm, moist air. Now, albuterol would be useless on this kid because albuterol works on the bronchioles. This is the larynx. Epinephrine, nebulized epinephrine would work on this, but EMTs are not allowed to use that. Okay. Now, the next one is a much more serious one. It's called epiglottitis. So the first thing is epiglottitis does not happen very frequently anymore in kids who take vaccines. You're going to see epiglottis in kids whose parents do not believe in vaccines, but there's a vaccine called the HIB, H-I-B vaccine, Haemophilus influenza B strain vaccine, that gives some protection to kids from epiglottitis. So it's not so common really in young kids anymore. We still cover it in the pediatric section, but it could really happen at any age. It doesn't have to be a pediatric disease. It's just that before that vaccine was developed, it was more common for kids, young kids, to have it than anybody else. So these kids look much sicker than the croupy kids. Remember, croup is viral, not usually that much of a big life-threatening emergency. Scary, but not usually a huge life-threatening emergency. Epiglottitis is a life-threatening emergency. And again, it could happen to anyone in any age, but it's just more likely in kids who are not immunized to get it at a younger age. So they tend to have a very high fever and they have the worst sore throat of their life. So what's happening is, the epiglottis is that flap that we were looking at that we said helps close the airway when someone swallows and makes the food go into the esophagus. In epiglottitis, there's an infection in the epiglottis that's causing it to swell. And they basically get the worst sore throat of their lives. So because of that, just picture when you had a really bad strep, infection, it becomes you don't want to talk and you don't want to swallow, because it hurts. So they tend to talk very quietly, and they tend to not want to swallow, so they actually drool their saliva out versus trying to swallow it. They may, again, lean forward, sitting in that tripod position to help them drain their secretions. They tend to sit very still, concentrating on every breath because they feel like, they know something is very seriously wrong and stuff like that. They definitely look very sick, right? You're not going to mistake this as, a kid who's not very ill. They're very toxic looking, very sick looking, high fever, and stuff like that. They want to sit up because it helps with the draining of the excess saliva. So they're never going to want to like lie down or anything like that. So even the parents say, I was trying to get them to rest, but they wouldn't rest. They only wanted to sit up. Okay, that is very classic of epiglottitis because they can't drain out their saliva because it's just too painful for them to swallow. Okay, now this is what we're looking at. Okay, so let me just orient you to what we have here. So this is a bronchoscopy. This is a camera going down a patient's throat, okay, and looking into their larynx. So this is the opening to their trachea, okay. The back down here would be the opening going down into their esophagus. The two little white lines, this is a normal healthy one, okay. The two normal white lines you see here are your vocal cords. When you go through this opening, okay, you're in the trachea. This is your epiglottis that again is going to, when you swallow, okay, it's going to meet your trachea or your larynx and shut this area off so that the food goes down here, right? Because you only want air to go in over here. This is showing you, whoops, a patient with epiglottitis, okay? Now, what happened is, here's the epiglottis, that's it right here, but it's so swollen that what did it actually do? It shut off the opening to the airway. Now, what you're looking at over here is that they managed, probably before the swelling was complete like this, to get an endotracheal tube in. So they're able to breathe for this kid, even though his airway is shut because of the fact they have this endotracheal. So now when they hook the bag valve mask right up to it and blow air into it, it's still getting into his trachea, therefore it's still getting into his lungs. Just one of the things I wanted to point out is it's never 100% seal, right? So here you see that there's a little bit of space, so that even if you had an epiglottitis that was 100%, unconscious, barely breathing, you could still try your bag valve mask to ventilate. The issue is going to be is that since this is pretty much closed and the opening to the esophagus is not closed, you are going to get some air in the stomach. But it's the only thing you could do to try to get a little air in the child until they get to the hospital. If this kid came into the hospital with this degree of swelling without an endotracheal tube, they would actually have to make a surgical cut in his trachea below his epiglottis and insert a breathing tube, right? Because that's the only way you'd be able to ventilate this child. So that's what that's what happens in a severe epiglottitis, okay, and stuff like that. They also get a lot of pain in their neck, like meningitis, because obviously this structure is in your neck. Very high fever, drooling, and stuff like that. This is just showing you should never ever be able to look down somebody's mouth and see their epiglottis, okay? But when people have epiglottitis, because it swells, you can actually see it. It's not something we do. These pictures are all like from India and stuff like that. It must be like, one of the things they do there. But, you should never be able to look down. Like if you ask your child to stick their tongue out as far as they can and you look down there, you should never be able to see somebody's epiglottis, okay? So what you get on an x-ray is something called the thumb sign, okay? So if we look over here, okay, so normally, well, let me just show you what we got here, right? So here's your spinal column, okay? Here's your mandible, okay? Here's your oropharynx coming down, right? And then here's your trachea, okay? Your esophagus, you're not really seeing well here because it's pretty much a flat tube until food goes into it. But this whole area, so here's the part of your throat right before it goes into your, okay, into your trachea, into your larynx, right? So this is a normal patient and the epiglottis is barely being able to be seen, okay? Here in a patient with epiglottitis, it looks like they call it a thumb. It looks like there's a finger stuck in their throat. And you could see here's the path for the air to come in, right? And it's completely obstructing it. Where here, there's still a passageway, right? It's over here, it's not in here. So that's what happens with it, okay? And then becomes, again, this is all swollen, inflamed, feverish, very, very painful. Hard for them to swallow, hard for them to breathe because it's blocking the opening to their airway, okay? So there's not much we could do for either one of these patients. You know, again, the croupy patient not too sick, the epiglottitis patient very sick. It's basically a quick transport without getting them to cry. You're never going to visualize their airway. One of the questions that's always on the state exam is, can you look in their airway? Okay, and the answer is no. Okay, because you don't want to do anything to make them aggravate this area anymore. It is. So if they'll tolerate some, you know, moist oxygen, some oxygen going through a humidifier, that's fine. But if any, you don't want to make them cry, you don't want to do anything to make them upset. Okay, these are life-threatening emergencies, but thankfully very rare. Somebody asked, warm shower is a myth. I guess you're talking about croup. So again, it's not inappropriate to bring them in the bathroom with moist air, but just cool moist air. In other words, turning the shower on to cold and having the kids stick their head towards, you know, the shower door, not going in the shower, but kind of sticking their head into the shower so they're breathing cool moist air, should do a better job than warm moist air. Okay, because cold reduces swelling. Like when we have an injury, we put cold on it to reduce swelling. Warmth, okay, kind of dilates the blood vessels, and if you dilate the blood vessels, you get more swelling. So cool moist air is better. But again, you will 99.9% of the time find people sticking their kids in the bathroom with steam and you can't even see, especially if you wear glasses. You walk in there and you can't even really see. Okay, other things we could have with kids. So we go a lot of times on kids with high fevers, okay? And sometimes kids have what's called a febrile seizure. A febrile seizure is a kid who does not prone to seizures. They do not have epilepsy or anything like that. They're not prone to seizures. But because their temperature rose so quickly, so high, the brain kind of gets too hot and they have a seizure. Very scary to the parents. The kid obviously a lot of times turns cyanotic. They see their muscles tensing. They see them shaking. The kid's lips turn blue. Very, 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 very scary. Okay. It does not mean they're going to have the disease of epilepsy. Okay. Although kids who have repeated febrile seizures can develop or can be more prone to having long-term seizures. But again, a kid who has an isolated febrile seizure once or twice in their pediatric life doesn't mean that they're going to develop epilepsy or anything like that. You know, most of the times it's one seizure. Okay. The kid is sleepy when you get there. Sometimes they're very cranky. They cry when you touch them and stuff like that. But it's usually stopped by the time we get there and it's no real serious emergency. If the child feels like they're burning up, you can loosen some clothing. Okay. You can try to give them like a lukewarm sponge bath where, you know, you take water that's not hot, but water that's not cold, right? So like comfortable water that you would use on yourself and just sponge them down a little bit. Okay. And what you're just trying to do, just like you do with your kids, is by putting, you know, by cooling them a little bit. Okay. You're trying to reduce their temperature, but you don't want to put cold water on them because if you make a child shivering, right, the muscles kind of shaking like that, that actually is designed, that's a reflex that we have to make heat, because when you shiver, the muscles rub together. And if just like if you rubbed your palms together, you generate heat. Friction, the rubbing of two surfaces together, generates heat. So you don't want to make them shiver. Okay. If they want to, you know, if they can safely drink some, you know, cool water or cool juice, that's fine too. Okay. You don't want to, you know, give them anything in their mouth if there's any chance they could choke on it or anything like that. Okay, now again, the febrile seizure is the seizure in a kid with no history of seizures that has it because they have a fever. So if a kid has a seizure without a fever, we would not call it a febrile seizure. We would call it a straight seizure and stuff like that. Okay, so in that case, probably a little more important to cool them down. Okay, to give them some supplemental oxygen and stuff like that. But again, we don't put kids in cold water. Sometimes you're going to walk in the house and the parents have the kid in a freezing cold bathtub of water. All it's going to do is make the kid shiver, and it's not going to make their temperature come down. Okay. And again, I don't know, you know, if anybody has, but years ago, instead of water, they used to say rubbing alcohol, which is not drinking alcohol. It's kind of like in a bottle. What kind of looks like, I don't know, but whatever. It's just a different form of alcohol. But if you put it on your skin actually feels cold. So they used to think it was a way of cooling a patient very quickly. But unfortunately, whatever you put on the surface of the skin is absorbed into the body. So actually it's toxic. So you would never use rubbing alcohol on a child or anything like that, or any patient. I don't even know why they sell it anymore. Okay. Now, the next thing we're going to talk about is meningitis. So you remember that the lining of the brain was called the meninges, right? And we had three linings. We had the dura mater, the pia mater, and the arachnoid membrane, and their wrappings around the brain. And then we had epidural hematomas, which is bleeding above the dura, pressing up against the skull. And we had subdural hematomas, which is bleeding under the dura mater, pressing on the other two linings and on the brain itself. Meningitis is that inside those linings is where the cerebral spinal fluid runs, okay? And it is an infection inside those linings that causes a very dangerous condition where there can be a lot of pressure on the brain, pressure on the spinal cord. There's different types of meningitis. There's some that can really kill very quickly. There's some that just give people headaches and make them not feel well. In the field, we have no way of knowing. The only way you will know is doing something called a spinal tap. A spinal tap means that they go down into their lumbar spine below L2, right? Because your spinal cord only goes down to about L2. And they stick a needle and draw out a little bit of that cerebral spinal fluid and look at it under a microscope so they could see signs of infection, okay? So there's no way in us in the field to differentiate whether it's meningitis, encephalitis, West Nile, any of these different viral types of infections or bacterial types of infections is something that can only be done in a hospital. So one is that a patient with meningitis is highly infectious. So you would need to be wearing similar to protection that you would wear with COVID, right? You need to have eye protection, an N95 or better face mask, gloves, full face shield and stuff like that. So because it is highly infectious, and it's so infectious that if the kid has bacterial meningitis, they would actually bring everybody who was on the ambulance crew back and have them take one dose of antibiotics just to protect them from getting it. That's how highly infectious it is and how dangerous it is and stuff like that. Okay, so again, we have patients with all different kinds of meningitis. I think I told you a story. We had an EMT student, who wound up having viral meningitis in class. And until we found out what type of meningitis it was, we couldn't hold class and stuff like that. I mean, it only took a day, but we couldn't have any classes and stuff. And the guy basically came to class complaining of the worst headache he had in his life. He didn't feel well, and he was a very dedicated student, never missed class. So I was like, well, when we're doing skills that night, I said, just go home. You can make up the skills. Don't worry about it. And he tried to stay and do it, but he just felt so sick. So he said, okay, I'm going to go home. So he walked out. And at the end of class, we walk out and see his car still in the parking lot. So we figured his wife came to pick him up or one of his kids came to pick him up. But one of his friends that was in class decided to go over and look in the car and found him slumped over onto the seat, unconscious. So we had actually break in, get him out. He only had viral meningitis, so it's a little surprising that he was sick as he was, and he did fine. He went to the hospital for like a week and he was fine and everything. But bacterial meningitis is very dangerous. There's actually a meningitis vaccine for kids, to prevent them from getting bacterial meningitis. So usually, again, if you were going to school in the secular school system, you would have to prove that you had that. If you're going to camps, summer camps, most, again, summer camps will require proof that the child has that, because meningitis spreads very well when there's a lot of people living close together, like at summer camps and stuff like that. The classic sign of meningitis, again, is the worst headache of their lives, okay, with a very stiff, sore neck. Okay, so again, and they call it nuchal rigidity. Remember, we said when the baby had the cord wrapped around their neck, the umbilical cord wrapped around it, it's called a nuchal cord. Nuchal is the term for the neck in Latin, I believe. So nuchal rigidity means that they keep their head totally steady because it hurts so much to bend it, and they cannot bring their chin to their chest. So if they have very bad headaches, high fever, stiff neck, okay, it's all common signs of meningitis. Remember, you have to protect yourself and make sure you have on proper PPE, okay? Vomiting and diarrhea, there's not much that we can do for those kids other than get them to the hospital, okay? So some oxygen and get them to the hospital. There's really not much we could do. Seizures other than febrile seizures, which is basically managed the same way. Remember, when somebody's seizing, they're not protecting their airway very well. They're not breathing very well. So we want to give them supplemental oxygen. It's always good if a kid has no history of seizures and they have a seizure to find out if there was any history of head trauma or anything like that. Obviously, if a kid has no history of seizures and they have a high fever, the cause is a febrile seizure. But if a kid has a seizure without a fever, one of the things we'd want to ask the family, is there any possibility, okay, of any head trauma hitting their head or anything like that? Because this may be a slowly developing subdural hematoma, which we say could take days to weeks to develop. and now it's finally showing its signs and symptoms. The other thing it's important to ask, is there a family history of seizures, right? So if there's a family history, the father has a seizure disorder, the mother, the grandparents, it could just be genetic. It just could be, this is the time it chose to come out. But the thing that kills seizure patients either is that when they have their seizure, they injure themselves by falling or drowning, or if they're driving a car, having an accident. The next most likely reason is the hypoxia, that during the seizure, they're not breathing well. So our role would be, is to, whatever we could do, supplemental oxygen or the bag mask, try to get some oxygen in them. Okay, kids who have altered mental statuses, very, very hard to pinpoint. But again, we do carry glucometers, so we could look and see what their blood sugar is. The only reason I say this is most of the times people know they're diabetics, but remember, in kids, it could be what they call new onset or first onset of diabetes. I mean, in other words, they didn't know they have diabetes. This is the first time it affected them, and you're the person that shows up. So if you say to the family, it looks like they're hypoglycemic because their skin is cool and pale and they're unresponsive and it happened quickly. Do they have a history of diabetes? The family say no. Okay. But it could be the first time their diabetes is, coming out and showing signs and symptoms. Again, that would be another time where it would be important to ask if there's any family history, right? It doesn't have to be that the parents are diabetics, even the grandparents. Sometimes it skips generations and stuff, but most of the times diabetes is genetic, okay? That in one side of the family, somebody at some point had diabetes, and it just comes out in certain patients, certain kids, could skip a whole generation. So the parents may not have it, but the grandparents have it. Okay. But again, it's altered mental status is playing detective. In other words, to try to figure out why somebody has an altered mental status, there's so many different reasons why. You just start running through the most common reasons and ruling them out. So if you think it could be diabetes, you're going to get a blood sugar. Okay. If they had no history of shaking and getting tight, it's not a seizure. So you just kind of run through the different ones. And if there's something you could do, you do it. But I mean, again, on a BLS level, unfortunately, there's not a lot of super treatments that you could do. Okay, poisonings. Again, there's no way of knowing what to do without calling. Now, here's the dilemma. We're not going to know what to do in every poisoning. And also, we probably don't have the equipment to deal with every poisoning. So most people would say when there's a poisoning called poison control. Poison control is an 800 number that's hooked up to a poison control center. Ours, outside of New York City, is actually in Rochester. Okay, in New York City, it's actually at I think Jacoby. But outside of New York City, any phone that calls outside of New York City, and it's a standard number. I think it's like I don't remember what it is. I usually have to Google it. But it's a standard number throughout the country. It's the same number. It's not a 3-digit number like 911, but it's a standard number throughout the country, and it goes right to the poison control center. The issue is that our protocol says that we're supposed to call medical control, not poison control. And it's a very simple thing, is that we can only take medical direction from a medical control physician, right? We can't take medical orders from a poison control center because we don't know who we're talking to. My experience is that if you would call the emergency department and say, we have a poisoning, what should we do? They're going to say, did you call poison control? Even though the protocol says to call them first. So sometimes we kind of call, I will call poison control, say, this is what we have. They ask you a lot of questions. They ask you the age of the child, the weight of the child. Okay, how's the child appear? Any medical history. Then they ask about the substance, right? How much, how long ago, and all this stuff. So you're going to be on the phone for a couple of minutes, probably asking the same questions back to the parents because you don't know all of the answers and stuff like that. Then once poison control says, okay, this is what we think you got and this is what we think you should do, then I usually call medical control and say, okay, we have this poisoning, we called poison control. They said, do this, this, and that. Is it okay? And if they say yes, then you have medical control's permission to go ahead and do it. The only, I would say, poisoning, if you want to count it as a poisoning, we usually call it an overdose, that we have something to treat would be an opioid, right? Heroin, Oxycontin, fentanyl. We have the naloxone or Narcan. Really, anything other than that, we don't have any real way of antidote or anything like that to treat it. So, sometimes poison control, if it's an ingested poison, something you swallowed into your stomach, they may tell you to have them drink water to dilute it, or they may tell you to drink milk to coat their stomach. But again, if there's any chance that the patient's going to become unconscious and then vomit, you wouldn't want to give them anything into their stomach or anything like that. Okay, drowning patients. So the first thing is, find out if there's a story of the child diving in and possibly hitting their head. So if there's a possibility of that, then you have to think there may be a need for spinal immobilization, right? If they're jumping into a shallow pool and they hit their head, they could have fractured the vertebrae in their neck. If they jumped into a shallow lake and hit a rock or a tree that was submerged they didn't see. So always that's one thing you want to ask. If the story is that people say they saw the person swimming, okay, and then all of a sudden they went under, then obviously there's no spinal injury. But if the story was they dove in and they didn't come to the surface, there's a possibility there's a spinal injury. So the rule basically is that once you get the patient out of the water, you just treat it as a regular cardiac arrest and you start CPR and ventilate them. There's no need to do any suctioning before. Now, as you're doing chest compressions and ventilating them, a lot of water starts coming up, then by all means suction. But years ago, they used to say suction first and then worry about CPR. But the bigger problem here is that they're hypoxic and you want to start ventilating them. So it's just regular CPR, okay? If the water they was in was very cold, then try to dry them off and wrap them up if you can and stuff like that. I mean, one of the big decisions is this kid still, in other words, is the drowning so short in time that you can actually try to resuscitate that kid? And that's a tough decision, especially when it's a kid, right? So, I mean, if this was an unwitnessed drowning and the body floats to the surface hours later, obviously there's nothing you could do. But most of the time, somebody witnesses it, somebody jumps in, somebody pulls the kid out. And in that case, we would be very aggressive in working that and stuff like that.
Now, if you have to do spinal mobilization, you still do it in the water or you take him out first?
So we are not trained in water rescue, and we are not trained in doing spinal immobilization in the water. So I would say as best you can to stabilize the kid's head and back and just pull them out. If the water is shallow and you feel safe to walk in and you could bring a spine board or backboard in and slide it under the kid, that would be better. But we're not trained in that. So there's no expectation that we would know how to do that. And you don't want to become part of the problem. In other words, if you jump in water to save someone and now you start drowning, then what's going to happen is everybody who came to help the kid is now going to jump in to try to help you. And then maybe there's other people who are going to start. And then who gets neglected is the patient. So it's a tough situation. I mean, you don't want to be standing on the shore watching somebody drown. But the same token, if you don't know how to swim, jumping in the water is just going to take your life at risk. And those of your lifeguards know that even if you do know how to swim, if you swim towards somebody who's drowning, they're going to jump on top of you when you get close enough to try to stay above the water, even if it means pushing you under the water. So you really need to have lifeguard training to rescue somebody in the water. The next best thing would be to throw something that floats to the patient in the water, okay, to the person who's drowning and have them hold on to it, okay? And if there's a rope attached to it, you could actually pull them to shore. Okay, so, I mean, I think it was last winter or the winter before in Florida, there was that Rebbe who took the kids to the beach in Miami Beach to swim. And, the lifeguards were off duty, so they shouldn't have been swimming. And, I guess one kid got into trouble, or I don't know if that kid drowned, but anyway, the Rebbe went in too, and they both wound up, drowning. So you just have to realize that is not an uncommon story, okay? Or somebody's, on the wintertime, somebody falls through the ice on a lake, and then other people go out and try to rescue them, they fall through the ice of the lake. So, unfortunately, trying sometimes to help people, if you don't know what you're doing, just makes the problem worse because now there's more patients and stuff. Okay, sudden infant death syndrome is abbreviated SIDS. So the first thing is there's no 100% agreement on what causes SIDS. So basically what SIDS is that is a normal, healthy baby, okay, is put to sleep for a nap, for going to bed, okay, and then they never wake up. So it's a terrible thing. So let's say, I don't know, the kid goes in for his 11 o'clock nap. And usually the parents say he sleeps till 1 o'clock in the afternoon. So now it's 1:30, the kid didn't wake up. They go in and check and they find him, with no signs of life. And they call 911. Okay. Or the kid goes to bed at night like they're supposed to. The parents wake up in the morning because the kid's not up and they find him dead in bed. So it's nothing the parents did wrong. It's nothing the kid did wrong or anything like that. It's just this phenomenon that happens sometimes. They don't know what causes it. So what they did, a very interesting thing, because they didn't know what causes it. What they did is they basically, throughout the world, this happens throughout the world, not just obviously in the United States, they basically interviewed the parents of kids who died of SIDS. And they said, you didn't do anything wrong. We want to ask you a series of questions to see if we could do something to prevent this from happening to someone else. So they asked him, what position was your child sleeping in? Was he on his back? Was he sleeping face down? Was he on his side? Okay, what was the temperature of the room? Were there any pillows, any blankets, any bumpers, the soft fabric around the edges of the crib? They asked all these kind of various different questions. And then they analyzed all that data and looked for things that were common in kids who died of SIDS. So if it was common, it turned out it was common that the kids were laying face down. So they now say that it's safest to put a kid to sleep sleeping on their back. Okay. The kids that died of SIDS had pillows. So they said not to have pillows. The kids who died of SIDS had stuffed animals. They said don't have stuffed animals. They had bumpers. So what they basically recommend now is that a child is put to sleep on their back. Okay. And there's nothing in the crib except one fitted sheet on the mattress. And the kid is put to sleep in what's called a onesie, like a sleeping bag type of nightie. And that's it. Nothing in front of their face, nothing that could obstruct breathing, and that's it. Okay. And that the temperature of the room should be on the cooler side, not above 68 degrees. Okay. So I know this probably violates a lot of what everybody does with their kids, what their parents told them to do with their kids and everything. But since they have this, what they call the back to sleep program. So back to sleep means the kid sleeps on their back. It has really reduced the incidence of SIDS death a lot. You very rarely hear about it. And I know some people are going to say, well, if a kid's sleeping on their back and they spit up, they're going to choke on it. I had all the same things as you, but statistically it's proven that this is the better way to do it. Okay. Now you only have to worry about it until you come in and find a kid that's, the kid, your baby, your young baby has started to move around inside the crib on their own. So once the position you find them in is not the position you put them to sleep in other words, they're actually able to move on their own, their danger of SIDS death goes away because their muscles are strong enough at this point. They believe what happens when they go to sleep face down is that every breath requires them to lift their chest, right? You're laying face down. So every time you breathe, you have to lift your chest up. And that if you have any pillows, stuffed animals, bumpers, if your face is up against them, you're rebreathing your carbon dioxide. You're trapping some of your carbon dioxide and rebreathing it. Now, what about us? So here's what happens, okay? If the child is obviously dead, they have rigor mortis dependent lividity, there's really nothing we could do, okay? The problem is, what are you going to say to these parents? Your kid's dead, there's nothing we could do. I mean, it's a horrible thing to be put in this position. So every case is going to be a little different, okay? But if the child doesn't have rigor mortis dependent lividity, you work it as a regular cardiac arrest. Transport them to the hospital. The likelihood of them surviving is nothing, 0. But at least at the hospital, they'll have specially trained people who could break it to the parents and be there for the parents and stuff like that. Now if you have a kid who's obviously dead, I mean, they've been dead for hours, they have rigor mortis, they have dependent lividity, you have to kind of, it's tough, but you have to kind of play it by ear and see if you think the parents can handle the news. I usually do not work those kids. I usually say to the parents, I'm very sorry. Something happened. Your child died in their sleep. They didn't suffer. Okay. And there's nothing we could really do. If you want to be with them, you're more than welcome to be with them. But there's nothing at this point. They've been dead for hours. There's nothing we could really do for these kids. It's terrible. I mean, you're not going to sleep that night, I'm sure. But thankfully, it doesn't really happen that often anymore. It's very rare, okay, that it happens, especially if the parents are following the recommendations of the pediatrician on how the child's to sleep and everything like that. And again, like I said, usually, a couple months into it, when the kids start moving around in bed and stuff like that, it's not an issue anymore. The risk goes away. Okay, so any questions on the medical emergencies before we do the trauma emergencies, and then we'll be done. So it's about 10 o'clock. Okay, so what's the issue with kids? So the kids are, once they're mobile, right, they can move around. Once they get to the toddler age, they have no sense of fear. They have no sense of danger, right? So they're just very likely to get into problems unless the parents are watching them all the time and safeguarding the house, okay, and stuff like that. So, all the things that happen. You hear all these horrible stories, kids left out unsupervised, running, in front of cars, chasing balls, riding bicycles, falling down steps. You hear all the stories and stuff like that. Again, because kids are not as well developed as adults, they don't protect their body as well, right? Their bones are not as hard. They don't have as much muscles over their injuries. So, I mean, anybody who gets hit by a car is going to be, in danger, in a dangerous situation. Anybody who's inside a car that gets into a car accident, it could be dangerous. They're not restrained. But obviously, if a kid's inside a car and they're restrained in a child safety seat, okay, and it's properly fitted and it's the right size and everything like that, the chances of them being injured, just like, I mean, you're going to go on car accidents where you would think everybody's dead inside the car. You pull up, the car's destroyed, and you look inside the car, there's nobody there, and they're all outside walking around. The newer cars are built very well to survive accidents, right? You have airbags and more airbags and seat belts that tighten and car seats that are built the right way. And the doors have metal bars built into them to take impact. So, I mean, it's sometimes just amazing how crushed cars are, and people are fine either inside or actually got out on their own through the side that's not crashed into. It's the same thing like kids. Kids that are properly restrained in the right way in a child safety seat usually do very, very well in a car accident. Kids that are not restrained properly or not restrained at all don't do well. So, what you're going to have depends on every situation. There's no way of knowing where the injury is going to occur. That's based on your physical assessment, right? So, I mean, if they get hit by a car and it's hit in their abdomen, they're going to have abdominal injuries. If they're taller and it hits their legs, they're going to have, fractures in their legs. So, there's no way of knowing. That's based on your physical exam of what happens. So when we do a physical exam, okay, on an unconscious patient, it's fine to do a head to toe. But again, they were saying before, in a medical pediatric patient, to be less threatening, less scary to the kid, we would start at the feet and work our way up. But when you're doing your head to toe, just like we talked when we did adult, you're basically looking at every part of the skull. You're palpating, looking in the ears, behind the ears for battle signs, nose, eyes, mouth, right? Everything. Go down to the neck. Before you put a collar on, examine the back of the neck, the spine, the front of the neck. Go down to the chest, lung sounds, the chest rising and falling equally. Palpate the abdomen in all 4 quadrants. Palpate the pelvis. Okay, and then go back up and do your extremities. So every extremity you're palpating for trauma, looking for deformity, and then check pulse motor sensation, right? So it's the basic things that you always kind of do. So again, checking the pupils, palpating the neck, okay, palpating the chest, listening to lung sounds, making sure the chest rises and falls equally, okay. Again, abdomen, so it's hard to see, right? It's hard to see what's happening inside the body without a CAT scan. But again, with the abdomen, if it's swollen, distended, that could always be a sign of bleeding. It could also be a sign of a child who was crying a lot and just suck some air in there. Okay, extremities, again, we're going to compare one arm to the other arm as far as any injuries. We're going to palpate, and again, pulse motor sensation and stuff like that. When you palpate the abdomen, again, all 4 quadrants, okay, pelvis gently, okay, all 4 extremities, palpate for trauma, look for trauma, and then pulse motor sensation in all extremities, okay? Don't remember always that at the very end, the last thing we always do is the back and the buttocks, okay? So the KED actually does a good job in immobilizing kids. Okay, so this is what the device that you used in the car to take somebody out seated in a car, which we very rarely do nowadays, but it actually does a pretty good job in immobilizing a kid. So if you have nothing else, okay, I shouldn't say nothing else. If you don't have a pediatric specific immobilization device and you have a kid you suspect with a spinal cord injury, and they're actually going to allow you to do it. Remember, this is a stage picture. Probably this kid belongs to a photographer or one of the people. And, she knows there's no emergency. She's not scared. So she's lying very still. If this was a emergency setting, if doing this is going to make the kid move more than you just quietly saying to them, if you stay still, okay, we're not going to have to do anything. So just lie nice and still on the stretcher. Let your mother or father hold their head. That might be the safest way, because if this kid is going to fight with you and cry and move while you're trying to secure them, then you're jeopardizing their entire spine. So sometimes you have to use common sense. And if the kid is going to just lie still, that's all you do. And you just document that was the best way to do it. And you explain to the hospital that was the best way of doing it. So it's going to be the rare kid that's going to lie still and let you do that to them. Okay, just to realize. And that's why sometimes you can't do it. But in an unconscious patient, it actually does a pretty good device, pretty good way of securing. Okay, pediatric burns have to go to a burn center. So they're never going to be managed in Rockland County at Good Samaritan or Nyack Hospital. They have to go to a burn center. And, just like when we talked about burns, the severity of the burn depends on the degree of the burn. It also depends on the area that's burned. So certain things that are automatic high-risk burns, or any burns that involve the face and can involve the airway, any burns that involve any joints. So fingers, wrists, elbows, knees, right? Any joints or anything like that. Any burns that are what they call circumferential, which means that they burn completely around an arm, a leg, or a chest, because when the scarring develops, it's going to crush and not let any air in or not let any blood in. So those are all high risk. But again, there is no pediatric real care in Rockland County at all, but pediatric burn care is zero, right? So we have to take them to a pediatric burn center. Child abuse and neglect. So you are, once you become EMTs, you are what they call a mandated reporter of child abuse or neglect. So what's the difference between abuse and neglect? Abuse is the more serious thing, where there's physical injury to the child. Neglect means the child is not being fed well, the child is not being clothed well. Now remember, neglect is a very broad term. So I'll just tell you, since you're mandated reporters, it means you have a legal requirement to report child abuse or neglect when you are an EMT, when you are working as an EMT. Okay, so I'll tell you exactly. It's going to be Purim. You're going to go on a call, and the kid is going to be intoxicated. Technically, that is a reportable event because somebody neglected the care of that kid and allowed them to become drunk. I'm not saying that you're going to report it. You should. Okay, I'm not naive. I mean, I don't think it's going to get reported, but you're legally responsible. So what happens is if the hospital reports it, so you bring that drunk kid into the hospital reports it to Child Protective Services. And the Child Protective Service does an investigation and realizes the ambulance brought that kid in. They're going to expect that you would have reported it. If you didn't report it, they could come after you both criminally and civilly and say, why did you not report that? And you could be charged with a crime, you could be fined, and you could lose your EMT card. So I'm just pointing it out to you that certain things that exist commonly in the Jewish world would rise to the level of either neglect or abuse in the secular world. Parents leaving their children in the care of a 12-year-old sibling, brother or sister, that would be neglect. You can only leave kids in the care of an adult. So if you're leaving your kids in the care of somebody who's not an adult, and something goes wrong, and the ambulance comes and the police come, okay, that could technically be neglect, right? I don't know. I mean, I'll give you a classic example. I had a neighbor who the way she dealt with her kids misbehaving was she put them outside for an hour, and it didn't matter what the temperature was. And it was just never stopped. You know, there was something going on in the house. I called the police, and the police took the kid because they put the kid out in, 20-degree weather. They had a coat on, but she just locked the kid out of the house. So when the police pulled up, the kid was outside in 20-degree weather, and that was it. And they moved away. So I didn't have the problems with them anymore. And hopefully the kids got, taken care of better than it seemed like the parents were taking care of them. So you just have to realize, okay, that's now. Two things. You're not obligated to report when you're not working as an EMT, okay? And the other thing is there's a legal term that says you cannot discharge that responsibility to anyone else, which means that you can't not report because you think the police are going to report, or because the paramedics are going to report, or because the hospital is going to report. So you can't say, I didn't do anything because I knew somebody else was going to do it. So everybody has a responsibility to report. They would rather get multiple notifications than just one. Okay. Now, the other way goes, you don't have to report if you don't really believe there's child abuse. So what I'll tell you what happens with the paramedics is that you will get some 18-year-old kid on the volunteer ambulance who doesn't know anything about kids, doesn't know anything about anything. They just became an EMT, and they go on a pediatric call, and the kid's not acting 100%, and they see some bruises on the skin, and they say, oh, must be child abuse, and they call Child Protective Services. If you don't believe there's actual child abuse, just because that EMT is reporting it, you don't have to report it. Okay, it's only when you truly believe there's child abuse or child neglect that you have to report it. Okay, and then obviously anybody who has kids knows that it is not uncommon for kids to have bruises on their body. Okay, just because kids do what they do, right? They're running around, pushing around, jumping and stuff. So in a well-acting kid, okay, with no kind of suspicion of abuse, having a bruise here or there on their body is not necessarily indicative of child abuse. Okay, but a kid who's scared, looks at the parents all the time like they're afraid to talk, and has lots of bruises, that could be a sign of child abuse, right? So now the interesting thing is, who else are mandated reporters of child abuse? Well, every police officer, every teacher, every clergy, all nurses, doctors, right? Social workers, they're all what they call mandated reporters. It means they have a legal requirement to report. They all have to go through training, and they have to redo that training every 3 years. EMTs are the only mandated reporters that do not have to go through specialized training to identify child abuse, nor do they have to go through refresher training to report child abuse. So you have the same legal requirements with less information to be able to do it. But the fact that you have less information doesn't exclude you from the fact that you have a legal responsibility to report child abuse if you come upon it. Okay. So there's lots of different types of abuse and neglect, right? It can be psychological, where they're mean to the child, or yelling at the child all the time and stuff like that. Neglect means they don't give them proper food, clothing, schooling and stuff like that. It can be physical abuse where they're hitting the child. It can be sexual abuse. So there's a lot of different degrees of it. And again, we're not experts in it and stuff like that. So all possible signs, again, and again, we're not talking one minor cut, one minor bruise or anything like that. It's when they have these all over their body and stuff like that. Obviously, bite marks are not normal unless they're been bit by their sibling and stuff like that. Kids with repeated broken bones, okay, injuries that can't be explained, right? Those are all common. Burn marks, especially cigarette burn marks. Shaken baby syndrome is that in young infants, sometimes, the kid just doesn't stop crying, and people sometimes get so frustrated, they just pick the baby up and shake them. Well, the blood vessels in their brain are not that well developed, and sometimes it causes those blood vessels to tear and bleed, and they develop an intracranial bleed. It's called shaken baby syndrome. It's very rare, okay, but it's, it happens when a child is literally like shook, very, very, very hard for a long period of time. I'll just tell you a story that happened here in Rockland County with broken bones. There was a mother in New City. She was actually Jewish, not from, who had a daughter that kept on breaking bones with very stupid stories. Like, I mean, the silliest things in the world, nothing that you think would ever cause a broken bone. And the mother kept on either calling the ambulance or taking her to the hospital herself to have these fractures dealt with. Well, over a couple of years, she went in 3 or 4 times to the hospital with broken bones. It got flagged by the hospital that she kept on coming in with the same child with broken bones, and they reported it to Child Protective Services. Child Protective Services took the child and gave it to the grandparents for custody. The grandparents and the mother then took the child to a pediatric orthopedist in the city, who discovered that this child had a genetic problem with very weak bones, and that was what was causing the fractures. But even with that documentation from the pediatric orthopedist, it took 6 months for that parent to get unsupervised time with that child. In other words, to get that child back, right? The mother was always allowed to see the child and be with the child as long as the grandparents were there, and the kid lived with the grandparents. But the mother was not allowed to be with that kid alone. But even after they knew what the problem was, it still took 6 months for Child Protective Services to wrap up their investigation and give full custody back to the mother, because the mother did nothing wrong, right? It was a genetic problem with the kid's bones. Now that obviously is tragic, because that traumatized the kid. I mean, at least they were with the grandparents, so it wasn't like they put them in foster care. But and it obviously traumatized the mother, and it was a cost and everything like that. So that's kind of where it didn't work. But then you also hear all these horrible stories of child abuse that was well documented, and Child Protective Services completely misses it, and then the kid winds up dying. So I don't understand how in certain circumstances they're overly cautious, and other circumstances they miss obvious signs of child abuse to the point where the child dies. But that's basically what you face. So again, you are mandated reporters. You have a legal responsibility to report suspected child abuse and neglect. If you do not, you can be criminally charged, civilly fined, and you could lose your EMT card. Okay, so I told it to you, and what you do from there, is whatever you do from there. Okay. Obviously, if you suspect child abuse, you should not point it out to the parents. You should call the police and have the police come, and any evidence, okay, should be preserved, right? Any signs or anything like that you see and stuff like that. When they say you have a legal responsibility to report it, it means that there's an 800 number to Child Protective Services that's manned 24/7. So you, as quick as you can, after, when you're not involved in patient care, you would call that number and verbally report it. And then within 24 hours, there's a written report that you have to submit to them And usually what will happen is they will talk to you over the phone and tell you all this. And they'll say, take all the information from you and then say, okay, we're going to need you to fill out this form and put everything in writing. And it's a fillable PDF, on the internet that you just kind of type in the information and stuff like that. Sometimes it's obviously hard to separate the child from the infant to be able to talk to them, or the child from the parents to be able to talk to them and stuff like that. But you never want to let the parents know you suspect it, because then obviously they're going to start trying to develop an alibi on why it's not that or anything like that. Okay. Again, you don't want to say there's child abuse. You just say suspect it and stuff. That's just a legal thing. And again, there's a state thing. Okay, the last thing we're going to talk about is kids with special challenges. So that means kids who have chronic medical problems, okay, that are being managed in the home. So they found that it's really not best for kids to stay in hospitals for a couple of different reasons. Obviously, they're away from their family and they're not developing the same way, psychologically because of that. The other thing is that when you're in a hospital, there's always a chance of you picking up a secondary infection that's floating around the hospital. So years ago, kids that were sick stayed in the hospital for months and months and months. Okay, but nowadays they try to get them out, even if it means they need to be on special machines or anything like that. What they basically do is put those machines in the kid's house, train the parents, and then provide skilled, nursing care and stuff like that to those kids. Okay, so it could be many, many different reasons, right? Kids born with any kind of problem. Sometimes kids get older and outgrow it. Sometimes there's surgeries that could fix it. Okay, or sometimes this is it for the rest of the kid's life. But what happens is the kid's bedroom looks like almost a little intensive care unit, right? They have a lot of different equipment. They may have special tubes inserted into their trachea to be able to breathe for them and stuff like that. It's beyond the scope of an EMT class to go through and train on every single problem that you could have. But most of the times the parents, or there'll be a nurse or somebody with the child who's kind of an expert in what is wrong with the kid, who you could depend on in talking. So, here's a picture of a kid with a tracheostomy tube in place that's hooked up to oxygen. So imagine if this tube got pulled out, right? This would be a life-threatening emergency that we really have no means of, putting back in or anything like that. So you could try to ventilate them and see if air would go in. You may have to ventilate them through the hole in their neck versus their mouth. Okay, but it's really, there's nothing you could do but fast transport to the hospital. Okay. So again, home artificial ventilation, whether it's ventilators, whether it's just around trachs and stuff like that. They may have special IV lines in to give them antibiotics or medications. Okay, so there could be bleeding. Obviously, if there's bleeding, it would just be direct pressure. There can be feeding tubes. Sometimes when there's feeding tubes, people don't realize how much they're actually instilling. So this is connected directly into their stomach. They don't realize how much they're feeding. They could feed them so much that they actually force food up their esophagus and block their airway. So there's all kinds of crazy things. This kid looks like they're both on a breathing, because there's head ups here, and it looks like they're on a tracheostomy tube, plus they have a feeding tube. So there's obviously multiple issues going on with this kid and stuff like that. But again, the parents tend to be experts in their care, or at least know enough about their care that they could kind of point you in the right direction. Kids with feeding tubes typically should be transported. I mean, most of the times we transport all patients sitting up, but they should be transported sitting up just to reduce that risk of the food coming up and them aspirating it. Shunts are put in kids who have a disease called hydrocephaly. I don't have a picture of it, but hydrocephaly means that they produce too much cerebral spinal fluid. So they actually have pressure on their brains. So they install a shunt, okay, which is a tube that drains, if there's too much fluid, it drains that excess fluid, okay, usually down into their stomach, okay. So as long as the shunt is not clogged, they're fine. But the shunt gets clogged, the kid develops a terrible headache because there's swelling and pressure. So if the parents obviously know what the problem is, there's a shunt, they've been in the hospital probably for weeks dealing with all this and having the shunt installed, and they're told that if the kid has a headache, it probably means the shunt is clogged. There's nothing we could do. There's nothing that parents could do. So it's basically transport back to the hospital that's managing that kid. In other words, bringing it into a Good Sam or Nyack will do nothing for that kid. They need to be transported down to the hospital that has these specialized pediatric doctors who, neurologists and neurosurgeons who know how to deal with that. Okay. I actually see this. You'll see this sometimes in the Jewish world. You'll see kids who have, these conditions where they actually have shunts installed and stuff like that. Okay. Okay, so let's do a quick review. Okay, so we know we talked about assessments a little different in kids, where we tend to start in stable patients down by their feet and work their way up because it's less threatening. Okay, treatment wise, I don't know that it's dramatically different than adults, to be honest with you. Oops, I forgot to let somebody back in. Okay. But obviously there's going to be, little nuances. There's going to be little differences of how much we give and how we give it when we talked about with kids and stuff like that. Okay, we said there's anatomical differences, shape of the body, size of the body, and physiological differences where they need more oxygen, they need more sugar. Well, I shouldn't say need more sugar, but they need more oxygen, definitely. Okay, so we talked about that a little bit. Okay, again, airway breathing. So it's more likely for them to have airway problems because their airway is smaller. Their tongue, again, not as fully developed as far as a muscle goes. Shock care is pretty much the same. And again, we said in kids, the most primary reason kids have shock would probably be the hypovolemic diarrhea and vomiting. Could be sepsis, could be trauma with bleeding. Okay, those are the more common ones and stuff like that. Kids are more prone to hypothermia. Again, large head, large body surface area, large area to lose heat through. So we want to make sure we keep them covered and also keep their head covered and stuff like that. How do we determine an appropriate mental status in a kid? So that's hard. So it depends on whether or not if they're talking or not talking. We could always ask the parents or caregivers if they appear appropriate. We also want to see how they react to us being there, like are they kind of watching us? Are they looking to their parents, like they recognize their parents and stuff like that? Okay, and again, do we involve the parents or caregivers? If the kid has a chronic medical problem and the parents or the caregiver is an expert in their care or at least knowledgeable in their care, then yes, we absolutely want to involve them in their care because they know probably more about the situation than we do. And we're called to the home of a 3-year-old child who's been running a low-grade fever all day and is now drooling. As you enter the child's bedroom, you hear what you think is a seal-like bark. So that's the barking cough. So again, low-grade fever means a low fever, drooling, bark-like cough. They're trying to gear you towards a croupy type kid, right? So in a croupy type kid, not much we can offer as far as treatment in the house. So it would be transport. But again, the parents may put them outside to cool them down a little bit. It may be that just the time it takes you to bring them from the house to the ambulance and around the cool air, you see them starting to improve. Okay. And again, we said as far as the shower goes, that technically a cool, moist shower, not that we're going to give them a shower, but we're going to sit them outside the shower and have them breathe in the cool, moist air, should do a better job in reducing swelling than a hot, steamy shower. Okay. So respect wrong with that kid. Okay, again, would be croup because it's a low-grade fever where epiglottitis is a high-grade fever. Okay, and the barking cough where croup, they don't really make much sounds. They don't even want to talk. I'm sorry, whereas epiglottitis, they have a high-grade fever and they have such sore throat that they don't even really want to talk and they can't swallow and they're drooling and stuff like that. Again, so we think croup, okay, and again, in the real world, it would be transport, some blow-by oxygen transport. Okay, we probably wouldn't stay in the house. But in the Jewish world, they may say, oh, sometimes we try to bring them outside, or sometimes we bring them in the shower or the bathroom and run the shower. I mean, you want to give it 5 minutes and see if it helps. It's not going to hurt the kid. Again, croup is not usually that life-threatening or anything like that. Oh, we had some questions. Let's see. Hold on, we had a bunch of questions. Okay, so David, intubating the patient will not help. Was that an epiglottitis, David?
Yes.
Okay, so the problem is you can't see where to put the endotracheal tube. In other words, if it's swollen, you can't see. So if you, here, let's go to this one. So in other words, if you suspected epiglottitis and it was like this, then by all means, you could pass an endotracheal tube. That's probably what they did here. They intubated the kid before it swelled, but when it's swelled like this, you can't see where to pass the endotracheal tube because it's covered. So that's the issue with that. So what they actually do is they make a, so your epiglottis, if you look at somebody's neck, the part that sticks out, your Adam's apple, the biggest part on your neck. So I can't really see on me, but it's probably like right here. Okay, that's where we're talking with your epiglottis. Right above here is with your epiglottis. So we find that biggest part and we actually cut into the trachea and then take an endotracheal tube and shove it down through that cut. So that's kind of what happens.
Cortisone shock won't reduce the swelling.
What won't work? What will not reduce the swelling?
Cortisone shock.
Do they put them on steroids? Probably, but it's antibiotics is the actual treatment because this is infection. This is swollen because of bacteria.
Right, but just to reduce the swelling.
Yeah, but steroids typically, there's no steroid that's going to go to work in minutes. The best, if you give intravenous steroids, you're talking like 20 to 30 minutes. I'm sure they probably do give them steroids, but again, it's really the first thing they're going to want to do is stabilize their airway. And, you know, if they can't pass an endotracheal tube the normal way, they're going to cut into the airway deeper in, like where we can't see further down, and just establish an airway that way. Once they get the airway stabilized, then usually they put the patient on very strong antibiotics. And within literally sometimes hours, it starts to reduce the swelling. So while the seizure is active, can you control and manage the airway? Very hard. Good question. So somebody's seizing. Okay, what can you do? Not much. Okay, I got to be honest with you. You try, but it's very, very, very hard to, you know, either, I mean, putting a non-rebreather on somebody who's seizing is a waste of time. So trying to use the bag valve mask is a little better, but the problem is that, you know, they're very tight or they're bouncing around. So it's very hard to get any air in them, but you try. There's not much else you could do. You try to do what you can do. Okay, for drowning, even with a pulse. So drowning would mean the patient's in cardiac arrest. So somebody wrote for drowning, even with a pulse, is CPR. So if you say somebody drowned, that means they're in cardiac arrest. So if they're in cardiac arrest, you're going to be doing CPR. If you had somebody who went under the water and shot to the surface and is coughing and gasping for air, then obviously no, they're awake. They don't need a CPR. Okay, you just give them supplemental oxygen. Okay, and did the SIDS numbers drop since you follow new protocols? Yes. So the incidence of SIDS since they put in the back to sleep program is probably to the point where you very rarely hear of SIDS deaths. Very, very, very uncommon to hear of kids with SIDS deaths. Okay, happens, but I would say prior to this whole back to sleep, I mean, again, this is about 15 years now, maybe even 20 years back to sleep. Prior to that, it would not be uncommon to hear of a SIDS death. Nowadays, very, very uncommon. You know, but you still once in a while hear it. And I'm not saying it's something the parents did wrong. They may have even put the kid to sleep on their back. So nothing's 100%. They do now say that the smaller,
carriages also.
hold on 1 second. The smaller, more premature the kid is, the weaker their muscles are, the more likely they are to have the SIDS. So sometimes, you probably, some of you had this, you come home with a small baby, a premature baby, they have what they call an apnea monitor. Apnea is the medical term for not breathing. And it's usually one of two things. It may be a strap, a belt that you put around the child's chest that has a monitor, and it's looking to see the chest goes up and down. And if it doesn't see the chest going up and down, it sends a signal to an alarm that's, you know, usually in the room with the kid, a very loud alarm, which wakes everybody up. The newer ones actually have Bluetooth technology where they could send an alert to your smartphone and stuff like that. So that's one type. The other one I've seen is where it's kind of like a mattress pad that you put in the bed, and it senses the kid moving up and down when they're breathing. And, you know, but the newer ones I see out there are actually kind of like a strap they wear, you know, very loose fitting, you know, it's not a tight, it's not going to interfere with their breathing or anything like that, but kind of like a harness type strap they wear around their chest. And it lets the parents know if there's any situation where the child doesn't sense chest movement. And if it doesn't sense chest movement, then obviously the child's probably not breathing well. And everybody, all those parents who have kids, preemies and stuff, usually they're given pediatric CPR training before they take the kid home from the hospital. Now, somebody asked, or somebody said something, and then I interrupted them. Somebody
You have stories with kids dying in strollers also.
Strollers as far as choking or from SIDS?
No, from SIDS.
I'm sure. I mean, sleeping is sleeping. It doesn't matter whether it's a bed or it's a.
This is lying on the face down on strollers. Not
oh, you mean they're putting them sleeping face down in strollers?
Not face down. So that's
on their back. I personally have never heard of a story of a SIDS death that wasn't in a crib. But if you're telling me you heard that, I mean, I'm not saying you're a liar, but I've never really heard of that. The only thing I've heard in cribs is kids sliding down and getting trapped in the straps and choking, or actually going through like the where the feet go and getting stuck in there and stuff like that. I've never heard of a kid, you know, put to sleep in a crib long, like for hours, and then not waking up. I mean, again, most people don't put their kids in cribs and let them, I'm sorry, in strollers and carriages and let them stay in there. They usually move them to a crib. So again, this just could be something like in the Jewish world type of thing. I don't know. I've never heard of that.
In Montreal.
What's that?
Was a story in Montreal in Canada.
Yeah, it could. I mean, I'm not doubting it. You know, I mean, listen, there was a kid in a, you know, outside in the mountains that was eaten by a bear, right? Was left out in a crib or a stroller or something outside and was eaten by a bear. So, I mean, there's a lot of strange stories, you know. I don't doubt it, but I've never heard of that. And, you know, like I said, most people would not leave their kid in a stroller sleeping. They usually, once they fall asleep, move them to, you know, the inside into a crib or something like that. Okay, does anybody have any other questions or anything else they want to go over?
And what's the point by croup that you change from a hot to cold? You told me that you said earlier that there's no point to put like next to a hot moist air, but
so here's what happens. If we have swelling, right, and we put cold on it, cold reduces swelling. Hot relaxes blood vessels, makes swelling. So cool air, okay, makes the swelling go down. Cold makes swelling go down. Croup is a problem with swelling, right? I showed you the picture. The airway is narrowing, it's swelling. So cool air, okay, it makes it easier. Cool moist air, I shouldn't just say cool air. Cool moist air makes it easier, okay, for the child to breathe, and it makes it easier for the air to go down, okay? Warm moist air would cause more swelling. Now, if a kid had a stuffed nose and you wanted to, you know, maybe make the room a little steamier, or they're having a lot of bloody noses and you want to make the room increase the moisture. So, you know, they really pretty much all the time now recommend cool moist air, like you see with even the humidifiers you could buy. Like I still have with my kids, the hot steamy ones, but most of the times when you go to buy a humidifier now, it's what they call a cold air humidifier, which means that it doesn't actually heat the water. It just turns the water into a mist and makes the room, you know, the air in the room a little moister. Increases humidity and stuff. So, you know, I'm not saying that I can't really think of a situation where steamy would be better than cool, but most people believe it. I mean, you're going to go on lots of calls where you're going to walk into a room or bathroom and the shower is going to be going. And if you wear glasses, I'm telling you, immediately you're not going to be able to see a thing.
yeah, but at Sola sometimes what they do is, I had it a few times with my son, they tell me to change it right away. They put them into hot air and then change them right away to cold. That's my question. What's the point of changing it?
I've heard that. I don't think I think that's just a nonsense thing. I've heard that, but so, you know, the concept is it's kind of shocking the airway type of thing, but I don't think, I think that's just, it's nonsense. I don't think
They
there's
keep
any.
doing this. I want to make, it's like I have croup my son in the middle of the night. They keep doing that. So I want to know what's the point of changing it right away.
I don't know of any medical reason why to do that. I think it's just, you know, misinformation.
Just cold air will have the same as changing it from hot to
you
cold?
try it. You know, if you have a kid who's croupy, see, I mean, you know, you'll be our experiment. You know, I mean, just see if not using the steamy works just as well as using the steamy and the cold. So just try.
All my kids group in, and I tried both.
And which
Not
works?
very-
Which
not
works?
very- Put it in a hot room, and then you go to the freezer or going outside.
Okay. I mean,
More
again,
faster, and even I spoke to my rabbi and say I can do it in Shabbos to put in the hot water.
okay. I don't know. Again, you know, rabbinical supervision of medical treatments is always one of the things that kind of makes me crazy. But I think you're talking more about making the water hot than you are the medical part of it. Whatever. Listen, I don't know of any medical reason why going from hot to cold. I mean, I could try to do some research, but I don't know of any reason why, you know, hot to cold will work any better. Again, what it really needs is cool, moist air. So that's why going outside in the back porch sometimes works, you know? So, I mean, if the concept was it has to be warm, then going out in a back porch in the wintertime is not going to make that kid any better. So, but you could try, like, there's nothing wrong, but just, you know, I would say if I had to do it, I would do cool, moist air. You know, you don't put them in the shower, have them sit right outside the shower, and start breathing in that cool, moist air, and it definitely will make them start feeling better.
If you're transporting a child with a croup, would you put a nebulizer with normal saline?
It wouldn't hurt them. Okay, it's not in protocol technically to do that, but in other words, he's saying usually in a nebulizer we have albuterol. Okay, but during the transport, as long as it's not going to make them cry or upset, it definitely wouldn't hurt them. If I was going to give them oxygen, I definitely would give them humidified oxygen, just like I would any kid who's having a respiratory problem. But it wouldn't hurt them. I do that all the time. You know, and if they won't actually use the nebulizer, then I just take the T piece off, the part that goes in their mouth, and just hold the actual round part just in front of their face. So they're kind of, you know, I mean, again, they may not like it. They may make them cry. You just don't want to make them cry, but just so that the air they're breathing in has a little more oxygen and a little bit of moisture.
Are you gonna put the albuterol, or are you gonna put
No.
a normal saline?
Nope. Albuterol will not work on the upper airway. Albuterol only works on the bronchioles.
Are you
So
gonna put in normal saline?
Yep, just some, exactly, just some normal saline. You don't have to use albuterol. It's not going to do anything for them. It's not going to help them. If anything, it'll probably make them a little more tachycardic. So you don't, they're already probably a little tachycardic anyway because they're scared. So you don't need to add to it. What else? Any other questions? Okay, what's the verdict for Motzei Shabbos? Do we want to have a little review class?
Absolutely.
Okay. Okay, so as long as there's going to be one person on, I'll set it up. Okay, and then if more of you want to come, that's fine.
I believe you're gonna have 15 people. That's my bet.
Okay, well, we've been averaging 15 to 20 people on Motzei Shabbos.
All right, that's what I'm telling you.
So, yes, so we'll do a review, and I think we'll start going over some test questions, and we'll use that as a starting point to see what else we need to review. You know, like tonight we went over.
How about we do it in person?
Well, you guys could be in person.
I didn't ask that.
No, I'm still in isolation. So I
Oh.
actually had 3 days off because I had an exposure, so I couldn't go to work for 3 days. I just got my negative COVID test back today, so I got to go back to work tomorrow.
I could have given you a negative one if you want.
It was wonderful to be off for a couple of days. Okay, so everybody have a good night. I'll send out the Zoom for after Shabbos. Hold on for a second. So did we not finish OB? Somebody's saying, do we have to finish OB? Did we not finish?
We have class tomorrow.
We have class tomorrow, yes, but that's for geriatrics and stuff like that. But somebody said we have to finish OB. Is there something I left off? Did I not finish the whole?
I think you mentioned that you're still going to go back to finish up some stuff. I'm not sure what.
They said you'll bring back the doctor or something.
It's funny too, because she actually asked me, and I didn't know what she was talking about. If I wanted her to come back. Let me see.
Frank,
Yes.
if you go on calls from COVID, then you can come to us.
All negative. We all tested negative.
Mm-hmm. Oh, here's where we left off. Yep. So we left off, we got a couple slides. Trauma, SIDS, we just did. Cardiac arrest. Okay, yeah. So we'll start with this tomorrow night, and we'll just finish. It says like 5 or 6 slides. The obstetrician did send me a message saying that she had a situation where the Hatzola told the mother was bleeding. She was pregnant. She stopped feeling contractions and she was bleeding. So it sounded like the baby had died and she was having like a, she was going to have an abortion, so to speak. The baby's just going to come out dead. And they basically told her that, I guess what the issue was, the mother wanted to go down to the city. That's where she's supposed to give birth. And they told her that there's no reason the baby's dead. It's better, it's safer just to go to the closest hospital and get it dealt with. And anyway, the baby was, the mother came to the hospital. The baby was still alive. The baby was delivered and is now like 6 or 7 years old. And the other reason Dr. Banks said to bring it up was that the mother, every time she comes in, and she's had 3 or 4 kids since then, every time she comes in for a visit, she brings up, why would they have told me that? Like, why did they tell me that? Why would they tell me that? So, I mean, she just said to realize that, we can't tell exactly what's going on all the time. So we have to just be careful what we tell patients and how we say it and stuff like that. And I think I told you, a case I had where there was some big rabbi here in Muncie who they called Hatzola because they thought he had a stroke, and Hatzola said, yes, he had a massive stroke. He needs to go down to the city. It's a big emergency. And then they didn't have a paramedic available, so they called us to come. And I walked into the room, and the guy clearly looked like he was having hypoglycemia, had a low blood sugar emergency. So there were a lot of people there. Everybody's praying, and all this stuff. And I said, does anybody know if he's a diabetic? And everybody said, no, he's got no medical problems. Anyway, he clearly looked like he was diabetic. So I got a blood sugar. It came back low. And I started, I didn't say anything to anyone. Everybody's screaming and yelling and stuff. I started an IV. I started giving him sugar. And within 30 seconds, he wakes up and says, "Nu, why is everybody here? Like, what's going on?" So it turned out the family was embarrassed to say that he was diabetic. So they didn't say anything to Hatzola or anybody who was there. And, he did look like he might have had a stroke, but he more clearly looked like he was having a sugar problem. And once Hatzola bought into the whole concept that he was having a stroke, and that everybody believed it, and that was it. And now all of a sudden, the guy's signing an RMA and staying in the house. So you just have to be careful. Like, I don't ever 100% say to somebody, this is what I think is going on. What I'll say to them is, it could be this, but I can't be 100% certain. You have to go to a hospital. We don't have the same training, and we don't have the same testing equipment that they have in the hospital. So, this is what we're going to treat you as if, okay, but, I'm not saying that this is 100% I'm certain. This way you're not diagnosing, right? Because when you diagnose and it turns out to be wrong, that's when you kind of look stupid or get in trouble and stuff like that. So you just have to be careful. People do look up, especially in the Jewish world, you look up to, Hatzola, EMTs and stuff like that. But, if people knew how little training really, we have or we offer, they probably kind of be surprised. Like, they expect that you're an expert in every aspect of medicine. It's impossible. None of us are. That's why doctors specialize in certain types of medicine. It's impossible to be an expert in every aspect of medicine. So you just have to be careful, and you be honest and say, listen, I'm not 100%, solid on all the things you're saying. I don't know all that stuff, but I'd be happy to listen to you, and get some information about it. And I'll do the best I can to take care of you. And that's, that's sometimes the best you could offer. It's better to be honest than it is to pretend to be an expert in everything and then be made to look, stupid about it. Okay. So tomorrow night, we're going to finish up with geriatrics. And a little bit of hazmat type of stuff. And then Motzei Shabbos will finish up. Actually, tomorrow we'll also finish up OB, and then Motzei Shabbos we'll start review. And we'll squeeze in as many review sessions as we can before you take the state exam. Because I think really after tomorrow night, we don't really have any specific topics to cover. I think we've done everything at this point. Okay. So everybody have a good night. I'll see you tomorrow night, and that's it, unless anybody has any questions. Okay, so everybody have a good night.